Good afternoon to all the doctors. It gives us immense pleasure and privilege to welcome you all for today's webinar, an initiative of Surakshit Matratva Committee of UPCOG, supported by Zenex MQ Pharmaceutical Limited. MQ is a research-driven, globally integrated company with significant presence in regulated markets. We at Zenex MQ are pioneer in integrated care for healthy motherhood from preconception to end of fourth trimester. We are really proud to be associated with you all through this webinar. With this, I would like to introduce you all Dr. Meenal Jain ma'am. She will be the coordinator for today's webinar. Meenal Jain ma'am is a professor at SN Medical College, Agra. She has won many awards, including Korean Award.
We can excuse me. We can skip this. Let us move to the session now.
Okay, ma'am. So
okay, thank you so much. Thank you so much. Okay, so good evening, everyone. Please put the flyer. Please. Good evening, everyone, and a very warm welcome to all to this webinar, scientific webinar hosted by Surakshit Matratva Committee of UP chapter. And today, as we all know, that the topic of discussion is preeclampsia, which is one of the most frequently dealt medical disorder during pregnancy. And so it is very important that we need to update. We should update ourselves on this topic. And for this, we have our learned desk of experts today, and who would be talking on about this topic at length. So let us begin. I first of all invite Professor Saroj Singh Madam, Head of the Department, Obs and Gynae, SN Medical College, Agra, who is also the chairperson of Surakshit Matratva Committee. Ma'am, please, I would request you to please deliver the welcome address.
Thank you, Meenal. We can skip this. Thank you, Meenal. It's my proud, respected Madam, our Chief Patron, Madam Usha Sharma ji, our patrons, Dr. Chandravati ma'am, Dr. Meera Agnihotri ma'am, Dr. Raj Doveja ma'am, Dr. Manju Verma ma'am, our guest speakers, not guests, but speakers, Dr. Sadhana Gupta, Dr. Preeti, our faculty, Dr. Nidhi, Dr. Richa, Dr. Rehana, Dr. Swet Savita Tyagi, Shikha Seth, and Dr. Nidhi Gupta. It's my proud privilege to welcome you all today evening in this second webinar of Surakshit Matratva Committee. This is our second webinar. First one was on anemia in pregnancy, and we have especially chosen this subject because this is another enemy of Suraksha of our mothers, which we are facing day by day. And it has a wide spectrum, right? Starting from mild gestational hypertension to HELP syndrome, which can even take lives of our mother, not only mothers, but even fetus or neonates also. Another important reason why we have chosen this subject is that because this is a subject full of mysteries. Every day, a number of theories are coming regarding its nomenclature, regarding its classification, regarding its prediction, prevention. Every day, our concepts are changing, and still we are not sure what to do to prevent these our females from having the preeclampsia. And that was the reason that we have selected this subject to update our knowledge, to update our skills, and how to save our mothers from this clutches of this devastating disease. It's my great honor to welcome our Chief Patron, Madam Usha Sharma ji, our dynamic driving force. Madam, you are encouraging and every time encouraging us to move ahead. Thank you so much for giving me this opportunity to chair this Surakshit Matratva Committee. I will try to do my best for this. And Madam Raj Doveja could not join us because of health issues, but she has sent a lot of blessings for Surakshit Matratva Committee as well as for UPCOG as a whole. She has very keenly said that I am always there whenever there is question of safety of mothers of our state. Every time you will find me with you, but she will not be able to join. Thank you, ma'am, for your blessings. Madam Chandravati and Madam Meera Agnihotri will be with us very soon. And I welcome our speaker, Dr. Sadhana Gupta, a very dedicated worker of not only UP, but Oxy. She has worked at different levels as chairperson of Safe Motherhood Committee, then at SAFOG 3 years she has worked. Ground level worker, I should say she is. And all our best wishes are with you when you are fighting for the presidential post for this year. So lots of best wishes and wholehearted support with you, Sadhana. Another speaker or faculty today is Preeti ji, who is chairperson of Safe Mother Committee now. So we will listen and we will have so many inputs from her also, and all our panelists. All welcome, Madam Manju Verma, my colleague, my co-chairperson, Dr. Richa Singh, Dr. Nidhi Gupta, Dr. Shikha Seth, Rehana, Dr. Savita, Dr. Anu Pathak. Everyone is full of knowledge and bubbling with knowledge, and everyone of you will get a lot of inputs from them. I welcome Dr. Manju Shukla, ma'am. All our audience will be greatly benefited from today's webinar. That I think. Thank you so much. And I thanks this MPure people for giving us technical support today. Thank you so much.
Thank you, ma'am, for this warm welcome given by you. Light is a symbol of brightness and prosperity. So to make this academic evening a blessed one, let us invoke the goddess Saraswati by kindling the lamp of light and wisdom. Please put on the video. Yeah.
Kurutvam kalyanam arogyam dhana sampada. Shubham kurutvam kalyanam arogyam dhana sampada. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Shubham kurutvam kalyanam आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः.
As sunlight expels the darkness of the mind, similarly blessings bring in a positive vibe in any of our endeavors. For seeking the choicest blessings for the same, I very humbly invite Padam Shri Professor Usha Sharma Madam, the Chief Patron of UPCOG, to bestow upon us her kind words of wisdom. Usha Sharma ma'am, please. Madam Usha Sharma ma'am.
मैम अनम्यूट कर लीजिए मैम.
मैम का म्यूट है अभी शायद.
अच्छा हो नहीं रहा मैम, कह रही हो नहीं रहा अनम्यूट.
अर्षद जी मैम का अनम्यूट करिए.
यस मैम.
हो गया
जी मैम.
Am I audible?
मैम प्लीज आपकी ब्लेसिंग्स चाहिए.
हो गया ना?
जी मैम.
Okay. Yeah. Thank you very much, Meenal, for a wonderful introduction. It is only love and affection of you all which always provides me strength that I am with you every time, and I really feel great pleasure to be with you all. Our respected Dr. Raj Babeja, I have no words to appreciate her, but the agony she is having today, we are also sailing in the same boat. We really miss our beloved member, Dr. Anurita, whom we lost in the month of, and it's really, we were also feeling so bad, but I know Dr. Raj Babeja just brought up like a daughter, and so she could not join us today. And my heartfelt condolences to my dear Anurita. And her memories will always be with her till my end, because she was a wonderful girl and a very, very active member of Meerut Society. Dr. Chandravati, he is a leader of every one of us, and she is such a protecting lady that all the time we feel protected and we never fail to have anything to go forward, and she's always with us. Dr. Meera Agnihotri. She is also like my right hand and is always with me to take this UPCOG forward. Our president, a very dynamic lady, Dr. Tarni Taneja, our secretary, Dr. Kirti, unfortunately, she is not with us, and joint secretary cum treasurer, Dr. Bharti, and of course, our chairperson, Surakshit Matratva committee, Saroj Singh, such a humble, such a polite, such a knowledgeable, such a competent girl that I always appreciate her efficiency. And today with her team, she is taking a very important subject of preeclampsia. And we have got a very competent and a worthy speaker, Dr. Sadhna Gupta, with us. And as Saroj said, that she is contesting for the presidentship, and we all from at least UP should support her because she is one of us. And I am sure we people are no less than anyone else in India. And then we have chairpersons ever smiling. मंजू अभी भी मुस्कुरा रही है, इतनी प्यारी सी मुस्कुराहट. And then Richa Singh, she is there. I always remember the conference she held at Agra, and all the time she was so busy and was contributing and looking after each and every one so nicely. And then we have got moderator of the panel, Dr. Preeti Kumar and Dr. Anu Pathak, and then all the worthy panelists, I can say, Amrita, Rehana, Nidhi, we have Savita with us, and then we have got Shikha. And, you know, I always say one thing, that all the members of UPCOG are so active and dynamic that I'm very fortunate to have all these members who are contributing such good academics on behalf of UPCOG. And then we have experts today, and I think Kirti is not well, she will not be there. But then we have got a strong pillar, Saroj Singh as an expert of this panel discussion. Master of ceremony, my dear Meenal, Mr. Arshad, as well as all other representatives from MCure, because we really thank you. Without your technical support, it could not have been possible. As just now Saroj said, that she has selected this topic, as all of us know, that preeclampsia is a medical disorder which is very commonly met with, though the incidence has lowered down a little nowadays. But even then, whenever it is there, it's really a very confusing task. And it's a great problem for the obstetrician. And they are actually in dilemma as regards the diagnosis and management of preeclampsia. We know that it is a disorder of widespread vascular endothelial malfunction as well as vasospasm. Earlier, we thought that probably it is idiopathic, but then nowadays we know that it is many times or frequently associated with Hapla syndrome, as well as the immunologic factors and genetic factors, which can be thought of as a etiological factor for this preeclampsia. We know that eclampsia presents in a very, very variable type of things, and sometimes it's very difficult. And you know, the deleterious effect is on the mother as well as on the fetus. There, as I told you, it is a dilemma. And so there are so many questions as regards the management, when to deliver, how to deliver. And these questions are so important for every one of us. And I feel it's really a great task for all of us who are managing such cases. But I'm sure with the evidence-based experience of the speakers today, like Sadhna Gupta and all the worthy panelists, we will certainly have recent updates of the answers of these questions. And I'm sure that the deliberations today will go a long way in updating the knowledge as regards the diagnosis and management of preeclampsia. With these words, Saroj, I really congratulate you as well as your team. And I really feel, and I'm very happy to know that since we have started these committees, the academic activities of UPCOG, Manju is here, Manju Shukla is one of the chairperson, Kiran Pandey is the other chairperson. And with the formation of these activities, these committees, I have seen that our academic activities have gone quite forward, which is really beneficial for every member of UPCOG. I congratulate you, Saroj, and your team. I wish this program a great success, and I am sure that all of us, if we just join together, we will certainly make this UPCOG above and above and above, and we will go forward and forward. Thank you all very much for extending your cooperation, your help, your support for uplifting this UPCOG, and wish this program a great success. And I also wish you all a very healthy and bright future. Thank you very much.
Thank you, ma'am. We are really blessed, ma'am, to seek these precious pearls of blessings from you. Thank you so much. Dr. Chandravati madam and Dr. Meera Agnihotri ma'am have not joined us yet. So we move further.
I think we can.
I now invite our very dynamic and energetic President, UP Chapter, Tarini Taneja ma'am, to please say a few words.
Dr. Meera, congratulations. First of all, so putting so much as it was, and that's such a good way, the master of ceremony. And first of all, mera pyar vara namaskar of 2022 to everyone here, all the dignitaries, faculty, delegates, and the platform provider, MQ Pharma. Congratulations to the chairperson of Surakshit Natak, Dr. Saroj Singh, for choosing such a important subject, as already the pulse we have heard from the mouth of Padma Shri Usha ma'am, and also the speaker, none other than the Sadhana Gupta. So she has the right speaker, and my heartfelt regards to Padma Shri, our chief patron, founder patron, what to say, the Usha ma'am. She is always there to cheer up all of us, and we get really motivated, our moral get really boosted up from the presence of Usha ma'am. We really say that some light of the, जैसे कहना है सूरज की कुछ रोशनी आ गई है, तो उषा मैम के आने से मेरे दिल में तो ऐसे ही कुछ हो जाता, I don't know why. So anyway, namaskar to everyone. Manju ma'am, namaste. Manju ma'am, I have joined. So my all the regards to our advisor, Padma Shri Raj Babajami. She is not here today because of the, I know she lost, we lost Anu. If she was also my good friend. So my condolence to her, to family, and to Raji. Definitely to ma'am. I've already put on the Facebook also for her. Then the Chandra ma'am and our patron, Meera ma'am, Chandra ma'am, they all are a very great leader. Manju ma'am, Manju Verma, Manju Shukla, everybody the star position in the EPCOG. And our secretary, Dr. She's could not join, Dr. Kirti Dubey, our joint secretary, treasurer, very dynamic, Bharati Maheshwari, and chairperson, Dr. Saroj itself. Then scientific program, the Sadhana is like a speaker. Congratulations, Sadhana, to be here. I really wish all the best for you. And I really say that we all UP persons should unite in our political issues. We should take the UPCOG, as ma'am already said, up and up. We should always say 3 cheers to UPCOG. In presence of our stars, Dr. Usha ma'am, all the patrons. And also chairperson Manju Barma and Shika Singh is there. Our chairperson dynamic Dr. Preeti is there. Dr. Anu Pathak is there. And Penan is also a very good friend of mine. So many can't leave them. Urmila, then Amrita, then Shikha, and Nidhi. Also this Sabita and Rihanna. And again expert Dr. Sarojit there. Dr. Reena is there. and definitely Meenal is there. So बहुत कुछ हम सुनना चाहेंगे, आज learn करना चाहेंगे साधना जी से and panel से about this such a pregnancy induced non-specific disease, very fatal preeclampsia, or we can say rather in the future maybe this we can be say the syndromic region for the preeclampsia, and it's can also be said it's the new onset of hypertension. We can can't prevent the disease, but modifiable factors like lifestyle, diabetes, comorbidities, hypertension can be modified. We can't change the age or family history, and there is a only mantra to we can't prevent, but we can really prevent complicated sequelae like morbidities and mortalities from the eyes, brain, lung, liver, kidney, and also the syndrome, health syndrome, and also the fetus complications. So mantra is only one. We should screen our patient, whatever the first antenatal visit, very vigilantly with the thorough and blood pressure especially. Protein urea may be there or not may be there. So we should, screening is the very important part. And now the biophysical, so many markers have gone, like the color Doppler for the spiral arteries is the gold standard. We can assess by them to rule out whenever we think if it is the patient having the risk factors. And also, if the patient is normotensive before pregnancy or at the first visit, like early pregnancy, and according to ACOG, if the blood pressure is 130 by 90 or probably 80, they have said, I think Sadhana will clarify. So we should be alert and guide the patient, counsel in elaborately to the patient. So I would like more from the Sadhana and our moderator. I think this subject is very important and very fruitful to all the delegates for the faculties. And thank you so much, Dr. Saroji, for giving the opportunity. Thank you so much. I just here just to listen you. And maybe after some time I may leave because I have to attend a marriage. So Abhi, I'm here for 1 hour. I'm here. So carry on. Thank you, Dr. Meenal.
Thank you so much, ma'am. Nice to hear from you.
I'm really very happy to say that हमारे UPCOG में बहुत से सितारे हैं और आगे बढ़ रहे हैं. मैं सामने प्रीति को देख रही हूँ कि रियली आई अप्रिशिएट हर एफर्ट्स कि इसने हमारे यूपी का झंडा गाड़ रखा है. भारती महेश्वरी ने झंडा गाड़ रखा है और साधना ऑलरेडी इतनी पोस्ट पे रह चुकी है और शी हैज कंट्रीब्यूटेड एंड आई थिंक वी शुड ऑल सपोर्ट हर फॉर द सेम सो दैट हमारा यूपी कम से कम ऊपर चलता जाए. हम लोग इसी से कम नहीं है.
Yes, ma'am. Thank you so much, ma'am.
It should not be should, but we must.
Yes.
That is the thing, we must.
Yeah.
We have to. There is no other way also. So this is my way. No should, no if and no, but it is there because we all, like we say, what is Preeti, which we have a long association, and with Bharti and with your all teachers, there is no way, no should, no, like also no thing. It is only one that we are one and we have to do because we are very good and very sincere in work. So this is just, sorry to interrupt you, but I have to say that it is the one thing which we have to be together, have to be.
And all our best wishes are with you. And after hearing all these encouraging words from the dignitaries of UP chapter, now let us start with the scientific session. And ma'am has already told us that it is a clinical dilemma till date. And we need to update ourselves. And for this, to talk about this topic at length, we have a very learned speaker with us today, Dr. Sadhana Gupta ma'am.
ये कैसे आ गया भारती का?
हाँ, to chair the session. ठीक लगाया था आपने अर्शद जी?
का ठीक था नहीं, पहले से भारती का लगा दिया.
अर्शद जी ठीक है ये. हाँ. To chair this session, I very humbly invite Professor Manju Verma, Madam, retired professor and head of the department, Prayagraj Medical College, and also the ex-president of UP chapter. Ma'am, it's a proud privilege to have you with us today. Along with her, chairing the session is Professor Richa Singh, ma'am, one of the most dynamic persons in the Department of Obs and Gynae, SN Medical College, Agra. I request Richa ma'am to please formally introduce our eminent speaker, Sadhana Gupta ma'am.
Thank you, Meenal. I extend my pranam to Usha Sharma ma'am and all the senior members, Manju Verma ma'am, Manju Shukla ma'am, Tarini ma'am, Saroj ma'am, for giving me this chance. And my dear friends, indeed, it's a proud privilege to introduce our learned speaker of today, Sadhana Gupta ma'am, such a well-known figure, and by her toil and labor, she has made a mark not only in UP, all over India, and that is her hard work is that she is contesting for the presidential post of FOXY, the most prestigious post for an Indian gynecologist. We are all there to support you, ma'am, because you are, and especially you are from Agra, so the soft corner all the more increases. But I would like all the members of UP to also contact their friends and ask them to vote for you and support you, ma'am, because it will be our UP moving forward and all of us will move forward. It is a teamwork, it is a pyramid. We work from the base and then we move up. So that spirit has to come in our UPCOG, and we should work and support each other. Ma'am is a well-known figure, and her stars in her crown are, she has been the FOXY representative to SAFOC from 2018 to 2021, the Vice President FOXY 2016, ICOG Governing Council member from 2015 to 21, National Editor of Journal of Obs and Gynae and SAFOC from 2017 to 21, Chairperson FOXY Safe Motherhood Committee 2011 to 2014, in which there were, she gave many FOXY focus and many books also, which are very useful for our postgraduates and for the clinicians. The Best Governing Council member in 2021, she received Padma Bhushan Kamalbai Hospital Award to reduce the maternal mortality rate, and she has worked a lot for postpartum hemorrhage and to reduce the maternal mortality rate. Dr. Mehru Dara Hansotia Award for Best Committee in 2014. Thrice FOXY Dr. DC Datta Best Publication Award. Thrice Corion Award for the Best Scientific Research Work. And I remember when I won the first prize at FOXY for the best poster, ma'am was next to me. Ma'am also won in AICOG Delhi, and I being next to her also. So that was my first introduction with ma'am, and she was so humble. I was so junior at that time, but I have that first impression of her. She's a very humble person. That is the beauty of her, is she's very humble, very hardworking. And if we look at her schedule, how she works from morning to night, she's an inspiration for all the young gynecologists of Uttar Pradesh and also India. So, ma'am, we are all there because we know so many, you have organized so many successful conferences, workshop, projects, trained so many people. We really want with wholeheartedly to you to win the election. Now I invite ma'am for her deliberation, and we are all waiting to listen to it.
So thank you, Richa, for kind introduction. And mera Sadar Pranam, Dr. Usha Sharma, Dr. Raj Baveja, Dr. Meera Agnihotri, Dr. Chandravati, Dr. Saroj Singh, Dr. Manju Shukla, and all the juniors ko mera Sadar or Pyar Bhara Pranam. And thank you, Dr. Saroj Singh. Saroj ji, I will say that for this opportunity, for being with you in UPCOG for very, very important topic, which has been, so it is visible, slides are visible. Slides are visible, Meena?
Yes, ma'am. Slides are visible. Please make it full screen.
Yes, I'm doing it. No, it's good. Okay. It is
Yes.
full visible.
Yes.
Full
Good,
visible.
good, good.
Yes,
Yes.
thank you. So, I bring greetings from Foxy Sapog AICOG, whom the Federation and the wings of Foxy which I have served. Just a minute, ये थोड़ा सा साइड बार आ रहा है, मेरे को थोड़ा सा देखने में दिक्कत हो रही है. Yes. Thank you. So I bring greeting, and it is our medical college, Dr. Usha Sharma, Saroji, Richa, Dr. Manju Verma, madam. So we are the alma mater of SN Medical College, Agra, and we, as a 1976 batch, we contributed and made it happen to have our own gate at SN Medical College, being one of the oldest medical institution and oldest medical school in the country. And this was a proud moment as a humble student of the SN Medical College. And actually what we see, what our feelings echo, that our institution from UP also get that much of pride and the place that what services they have done to the majority, to the large population of women and the large population of our country, and how our institution should have that respectful place in the Foxy and the international platform. So we are here to save lives. And coming to preeclampsia, it is a god, it is like a COVID, we don't know actually, so we give the many names. So it was toxemia of pregnancy, preeclampsia, eclampsia, HDP, and now it is also said gestosis. In this presentation, I will like to bring new insight and a new thought process from all the people, that how we look at the preeclampsia and the severe preeclampsia in a different way. We know that the hypertensive emergencies and the preeclampsia affect 3 to 5% of pregnancy, and the hypertensive disorder contribute to 10 to 15% of direct maternal death, and it is responsible for a good amount of perinatal morbidity and mortality. So Dr. Saroj Singh madam is really very apt in choosing, because it is one of the main contributor of the maternal as well as the perinatal death and mortality. In India, where we are around more than 35,000 mothers died not long ago, it is in 2017, and it is an important thing that hypertensive disorder of pregnancy and the preeclampsia is not decreasing, it is increasing. Because now we are having the changed obstetrical demographic, increased maternal age, and many mothers entering the pregnancy with the comorbidity. So it is on the rise, and we have to be very careful about it. So it is a very strong contributor to critical illness, life-threatening accidents, and the long-term complication. Now, this is also very important, because India has become a place for the diabetic capital and the metabolic disorder capital in not that elderly age. It is around 40 and 50, and we have to be very careful about the long-term output as well. So when we term hypertensive disorder, it is around 140/90 or 135/85, and it should be with a good cuff taken 4 hours, and I think Preeti will take it, and I am not going, but we must be aware of few things, that is white coat hypertension, masked hypertension, and delta hypertension. But only one thing I want to give message to all, whether there is even a single or occasional reading of hypertension, be it in the hospital, be it in the home monitoring, we should be careful, because quite a substantial proportion of these women get preeclampsia and severe preeclampsia. So no high blood pressure reading should be ignored. Whether you cannot say that it is only white coat or anxiety, and the people also want to believe it, but it is not so. Early onset and late onset preeclampsia, and one message I want to give, that early onset preeclampsia is considered the preeclampsia with severe features. So early onset preeclampsia itself is the preeclampsia with severe features, and it is a typically fetal disorder. We had the IUGR, we have the placental dysfunction and the abnormal umbilical artery Doppler, while the late onset PE is the milder form and it may not result into that bad outcome. Now, proteinuria is one thing. Once upon a hallmark of the diagnosis that the proteinuria should be there, must be there for diagnosis, there has been a complete change of process. Still, we have the classification based upon the proteinuria, that is preeclampsia with proteinuria. But it is very important that proteinuria is not considered mandatory for the diagnosis for severe preeclampsia, but it is a more system involvement. Whether it is a fetus, whether it is a liver, whether it is a kidney, whether it is a neurological. If there is system involvement, then we term it as a preeclampsia, and then we see for the severe features. So it is very, very important. Now, we are all confused because proteinuria is not considered as a mandatory criteria for diagnosis, and then whether the proteinuria have any prognostic thing, whether we should include it or not. So the important message I want to give that the proteinuria still is a very important criteria for assessing what is happening in the mother organ function. And what we are having almost always, the 24-hour urine collection has been always a clumsy and it is not a friendly thing. But if on urine dipstick, which we all have in our labor room, in our ward, and we should have these urine dipstick all around the day, if it is 2+, we should consider as a preeclampsia, and we should go for the further workup and the base categorizing the preeclampsia. One thing I will like to repeat again and again, that ISHHP, that is the International Society of Hypertensive Disorder, which is like consider what is the happening in the ground level. Whenever the junior consultant, house officer are seeing that preeclampsia should not be considered as a severe and the mild, because you never know that when the mild becomes severe. So it is very, very important that we, like, whenever there is preeclampsia, we should consider that it can turn up into the severe feature anytime. So this is the indicator of severity, what the topic I have to focus whenever there is a more than 160 by 110 millimeter of mercury, headache, visual disturbance, upper abdominal pain, less urine, conversion, creatinine more than 1.1, thrombocytopenia, raised transaminase level, IUGR, pulmonary edema, and early onset PIH or early onset hypertension, we should consider it as a severe. So severe is not only the high range of blood pressure, it is a organ involvement, and when we want to see organ involvement, we have to look for it. Actually, it is not that, like, it is not in the diagnosis. We have to search out in the symptom and in the sign. So severe preeclampsia, it is like a fire. Suddenly it is spreading all the organ, and we have to be ready with the formal fire drill. So many theories, and acute arthrosis is the something which has been added to our theory, and we know it is endothelial dysfunction, and there can be so many things. But this uncertainty, this theory actually is a matter of concern, because it is causing maternal and fetal life and the quality of life. So this uncertainty is very important, that we have a clear thing, and we must be aware of multiple processes which can cause the severe preeclampsia. This is one thing, very important thing which I want to communicate to all, that placenta is a villain or victim. And this beautiful paper says that it is a victim. And the cardiovascular performance of the mother is actually the suboptimal cardiovascular performance, or the cardiac dysfunction is the cause of placental malfunction, and that can cause the preeclampsia. And there is many good evidence and the experience for this. So this is another way to look at the preeclampsia. So whether you term severe preeclampsia, again I say that line boundary is very, very thin, and these are all criteria: liver, kidney, hematology, brain, fetus. When it is affected, always say that it can be the severe features, preeclampsia with severe features. And mind it that the creatinine level, what we take 1.5 around normal in the obstetrics, it is, if it is more than 1.1, you take it as a renal dysfunction, and platelet count less than 1 lakh per L, and the serum transaminase level twice normal. So this is very important, and the life-threatening complication can be many, which can come like a bolt in the blue. All over who are dealing with the emergencies, no, they suddenly come out of nowhere. Infarction, edema, stroke, and IRDS, coagulopathy and renal failure, and suddenly intrauterine fetal death. And whenever there is a progressive deterioration, we term it is a severe feature. So again, I say, because don't classify, because we are sometimes not able to identify. So how it is managed, it is based upon severity and the gestational age, and it is the what is we cannot predict, we cannot prevent, but it is a close surveillance that we terminate the pregnancy with least possible trauma to mother and fetus. We have a good, healthy newborn. We are able to restore the health of the mother. And majority of things can be achieved if we do timely induction and delivery of the baby. So that is the basic of the management of preeclampsia with severe feature. And it is important that we have to be very, very careful about blood pressure measurement. And when you suspect that this patient is having preeclampsia, admit it into the hospital and do proper workup, because 1 or 2 day workup will only make you settle that it is a preeclampsia with severe feature. This patient can be put on expectant treatment, or this patient needs the induction of delivery or termination of delivery. So this is very important, and many evidence say that if you go for the OPD management, sometimes it may work, but many times the patient comes with the severe features with the life-threatening complication. So this is very important that you counsel you. It appears thoda BP bada, but you have to be very meticulous, very compassionate, take her all socio-economic consideration and admit it for the workup. And what we do in the workup: weight measurement, proteinuria, if the dipistic 2 plus spot protein and creatinine ratio, this is important and equivalent to 24-hour urinary protein measurement, that is 30 milligram per mol. This is very important, and you can do up every 2 days. Blood pressure only when she is not sleeping, otherwise every 4 hours. Complete blood count, renal function and liver function test. LDH and the uric acid has got that like a question mark about the routine workup. And gestosis, our own Indian chapter, they recommend coagulation profile measurement only when platelet count is less than 1 lakh. Blood test evaluation at least twice weekly, and then according to change, like what is the status, and fundoscopy to differentiate between chronic and new onset disease. So we should be very clear that when we are admitting the patient for diagnosis and categorizing the preeclampsia, what we have to do and at what frequent interval, you have to repeat the lab investigation and you have to repeat the fetal evaluation. And what is fetal evaluation? Amniotic fluid index, fetal biometry, and if the baby fetus is IUGR, then of course umbilical artery ultrasound color Doppler. And again, our all result when we want to terminate the baby, it depends upon the normal umbilical flow, it is high resistance, or it is absent, or it is reverse. So this is very important that we have to be very, very careful about the fetal evaluation, because we want the main important thing is when to deliver the baby, when the baby is fine and the mother is also not compromised. Intrauterine growth retardation, especially in early onset preeclampsia, which is called a severe preeclampsia, when there is less than 10th or 33rd centile, the risk of perinatal outcome is not that good. So this is very, very important that we colored, and as an obstetrician, umbilical artery flow, like it is very easy to do, very easy to locate umbilical artery. And I think in my experience, because I always open the color Doppler in all third trimester scan, I have really picked out the baby with the absent and the reverse diastolic load, did cesarean in the like mid of night, and we could have a real good outcome. So it is not a very good, it is not a very technically taxing. We can all learn, but this umbilical artery Doppler is very, very important. So after baseline evaluation, we see that we have to do the expectant treatment or we have to terminate the this thing. And for this, we have to be very, very careful, especially if we are putting on expectant treatment because the fetus is 31 or 32 weeks. Always say whether the patient is having headache or visual disturbance, upper abdominal pain, thrombocytopenia on the rise, like lessening platelet count, and the other organ involvement. And the most important thing is that when there are omnious system, patient is having severe headache, patient is having visionary problem, patient is having like a low platelet count, then it should be managed with the like timely termination with the due stabilization of the patient. It is our gestosis on, and it adds LDH more than 800 and serum uric acid more than 8, add on to the omnious feature of the severe preeclampsia. Additional imaging, we are now too much fond of MRI and whatnot, but I think the ultrasound, well done ultrasound, well interpreted ultrasound is the best modality which has come to our rescue. Echo, when you suspect around peripartum cardiomyopathy or something different. MRI for brain imaging when we are like suspecting any like sinus thrombosis or something. However, neuroimaging is not recommended universally in all cases of even eclampsia. So again, I will emphasize that ISHP, especially considering the low middle income country, they don't say that people are complacent because it is only the mild or moderate preeclampsia. We cannot be complacent for any sort of preeclampsia, and we have to have our own protocol. What we say, because where only 5 million deliveries are happening, they are guiding us who are tackling with 27 million delivery, and we are not like very confident about ourselves. So this is the mindset actually which the world need to change, because we can have the healthy. What COVID says is no one is safe unless everybody is safe. So this is our confidence building and confidence in ourselves, that we have our own protocols, we have our own system, what level of expertise we have, and they all are competent enough to categorize, to diagnose and prevent complication. Like we don't want cerebral hemorrhage, we don't want hypertensive encephalopathy, we want to prevent them. And this is the thing where we have to work. So don't wait for the last wave, like don't wait for the complication. We have to be like work much more before that. Now coming to seizure prophylaxis, two things: seizure prophylaxis and antihypertensive regime. MAGPIE trial has said that the MAGSulf is like much effective than the what we have used to have our own Krishna Menon's like a cocktail and something. And there is again two issues. In high resource setting, they advise MAGSulf when the patient develops severe neurological sign or severe headache or clonus. But in low resource setting, what our recommendation says that all severe preeclampsia with severe features should get MAGSulf, because we are not that resource intense country and the resource intense setting. So 100 women need MAGSulf to prevent one seizure, but it is worthwhile. And the secondly, again, that we should have our own protocol, that MAGSulf should be given in what condition, and the preeclampsia with severe features when even when it's the initial diagnostic stage, we can consider, because it prevents seizure and it has the neuroprotection for the baby also. So it is Pritchard regime. We know now 4 gram 50%, 4 में 12 मिलाना है, then make it 20. It is like a table of 4, and 4 gram followed by 5 plus 5 in alternate buttock with the xylocaine injection. And the most important thing, that it should be available around that corner, around the clock, and it should be available in eclampsia tray, where we have got all the thing resuscitative measure. And it is not only for eclampsia, it is for prevention of seizure, like health, like severe high rise of blood pressure, so that we want to prevent the seizure. Many people are very, very like something apprehensive about complication, but it is a very safe drug. Usual what this dose has got the 4 to 6 milligram like magnesium level, and you have to observe only clinically. If respiratory rate is more than 16, patellar reflex is present, and urine output is 25 ml per hour, then you can safely go for the further doses of the magnesium. And the clinical clinical like observation is quite enough. Usually in most of the cases, we don't need to have the magnesium level. If there are sign of overdose, like the patient is having the reduced respiratory rate or loss of patellar reflex, then don't give further Maxel. Give oxygen nasal by mask, and sometimes we need assisted intubation, very, very rarely with the Maxel routine dose, and antidote is the 10 ml 10% calcium gluconate. So this is the basic knowledge we have to revise, and we have to communicate to our nurses and our junior doctors. And always it is a seizure prophylaxis which should be there, and it should be in our protocol. The second is the antihypertensive drugs. When to give, and when there is a severe preeclampsia, like severe features, we need that antihypertensive which have got a rapid onset of action, because we want to lower the blood pressure by only 15 to 25%, and it should have a short duration of action, because we don't want that it goes so low that the fetal fetal blood circulation is compromised. So 160 by 110 mm Hg, when it is more than this, we have got more hypertensive encephalopathy and the cerebral hemorrhage and so many complications. So this is the time for the parenteral antihypertensive, and we want to prevent congestive heart failure, ischemia, renal failure, stroke. And it should be initiated very expeditiously for acute onset severe hypertension, that is more than 160 by 110. And we all remember, like yesterday it was 140/90, 130/85, and today it is 160, and after 2 hours it is 170. In those situations, we have to go for the parenteral antihypertensive, and they should be administered within 30 to 60 minutes or as soon as possible. Now, the second thing, like 15 years ago, like we used to say it is 150/90 is okay, because otherwise we lower the BP and the fetal blood circulation and the placental perfusion will be compromised. So what blood pressure level we should target? I think the gestosis range is quite okay, that is less than 140/90 millimeter Hg. There is a little like professional body diverse, but our Indian chapter body says less than 140/90, and it is quite reasonable. Lobetalol, we know 20 milligram IV. After 10 minutes, if the BP is not reduced, then 40, then 80, and maximum 300. Nifedipine, which is the true drug which we use very, very commonly. Hydralazine is not that available, and usually we depend on lobetalol. One clinical message I want to give, that if the patient is having bradycardia, and when you are giving antihypertensive drug, put the patient on cardiac monitor. So you have a watch on the bradycardia pulse rate, and if it is bradycardia, then nifedipine is a good choice, and if it is tachycardia, then lobetalol is a better choice. And the maximum dose for lobetalol is 300 milligram parenterally. Orally, it is around 2400, and nifedipine maximum dose is 180 milligram. So this is very important thing, that we have to be very clear about the drugs what we use, and the oral nifedipine, never sublingual nifedipine, because it reduces the blood pressure to a markedly low level. So it is not advisable. Always oral nifedipine and oral lobetalol if the patient is on expectant treatment and you are observing or you are waiting for the drive time to terminate the delivery. What drug not to be given in pregnancy? That is ACE inhibitor, angiotensin receptor blocker. Diabetic to be avoided, because already the woman is in the reduced intravascular volume and it causes IUGR, as well as the patient is not, it is not good for the fetal electrolyte disturbance. Beta blocker only lobetalol and oxynolol, and calcium channel antagonist only nifedipine. So it is very important what drug not to be given as antihypertensive in the preeclampsia. So coming to eclampsia, it is a life-threatening complication. My tribute to Dr. Krishna Menon. Yes, just today in the Chennai Society, we heard with the Dr. Krishna Menon oration, and his lytic cocktail saved a lot of life. And in Agra, when we were resident, we used to do this, the same thing. When the patient comes with the eclamptic fit, it is first resuscitation. Now, this is very important, that don't push to the Maxelf and the antihypertensive. When the patient comes into fits, first of all check for the ABC. So lateral decubitus position, mouth gag, don't put tablet to like back of thread, which will cause the gag reflex. Then breathing, oxygen saturation, Now with pulse oximeter, COVID has, like everybody has got pulse oximeter in our top pocket. And if it is less than 92%, think of aspiration or pulmonary edema. Go for gas analysis, and goal is to prevent respiratory hypoxia and respiratory acidosis which occur during conversion. And circulation, crystalloid only 65 to 80 ml per hour, and the catheterization, so we know the urine output. And after that, go for the seizure prophylaxis and the antihypertensive drug. So this is very, very important, and do not try to arrest the first seizure. It is usually self-limiting. Maxsulf is the first dose. Sometimes the woman is so irritable that we are not really able to put the patient on the bed. How to put catheter, how to put IV line. Sometimes we can use diazepam or clonazepam or midazolam. Better anesthetic is on our side when we use it, because they depress laryngeal reflex, increase risk of aspiration. So these drugs are not without any sudden respiratory depression, and we have to be very, very careful about it. And it is eclampsia kit, which as a Safe Motherhood Committee, we are like propagating right from Dr. Sheila Mane to me to Preeti and all, that eclampsia kit should be there in our labor room. And after that, take the Maxsulf, and sometime in thiopentol and phenytoin infusion to be done. And one thing again I say, if the patient is having no control of it, or the patient is not coming out of coma, consider neuroimaging, because refractory conversion and refractory loss of consciousness can be due to the neurological thing, that is encephalopathy or the cerebral hemorrhage. And definitely for the next recurrent conversion, you can try Maxsulf. But if the drugs are not working, then think of the neurological complication. Fetal heart rate, this is again a problem, because once upon a time, seizure was totally like very unsafe. Now seizure has become safe, and the people are like quick to go for the cesarean section because the fetal is bradycardia. In conversion, the fetal bradycardia deceleration will be there. But when you resuscitate mother, that tracing comes to normal. So only after maternal hemodynamic stabilization, one should proceed to delivery, and it shows it is deceleration, and after resuscitation, CTG traces come to normal. And consider the delivery only when the mother is stabilized, and consider induction or watch for progress of labor or cesarean as per the obstetrical clinical scenario. HELP is one thing I'm not going to detail, but it is a form of severe preeclampsia. It is a one form, and we have a lot of classification, 1, 2, 3, partial and the full HELP. And it has got different codes, because the platelet count may be peak low in the first 2 days, even after delivery, and we should not panic. And if it is after 3 days, if the platelet count is low, then we should consider other diagnosis. But the important thing, and another important thing, even if the blood pressure is normal, treat HELP like severe preeclampsia with Maxsulf, with antihypertensive and a steroid, whatever it is needed. I will just put in this. And platelet transfusion to be considered in vaginal delivery less than 40,000, and in cesarean less than 50,000, because this is one thing which we have understood over the time, that don't rush to platelet transfusion, because people know so much about platelet now that they also sometimes pressurize us. But the what is the cutoff is 40,000 to 50,000 when we consider the platelet transfusion, and HELP is a form of severe preeclampsia. And again, we say that the HELP is not to be considered by SSP as a separate entity, but only the form of severe eclampsia. Steroid have got benefit only in the little rise of platelet count, not on the course of the disease. And what I say, ISSS does not recommend HELP management as a separate entity. Same management what is in the severe preeclampsia. We can have encephalopathy and hemorrhage, and whenever it is, take the advice of neuroimaging, neuro people, and do whatever imaging, and the multidisciplinary team. And the subcapsular hematoma, again, a very, very life-threatening complication, need a real ICU, real multidisciplinary team. It is rare, but seriously life-threatening. And we should be very careful. As an obstetrician, one message that whenever there is a upper right quadrant pain, sudden onset of hypotension and tachycardia, or the feature of DIC or abrupt elevation in liver enzyme, consider that it may be the subcapsular hematoma, and the surgery and everything needs a total multidisciplinary massive blood transfusion and component protocol, and we have to have a good surgeon also. Transfer protocol, very, very important. If you cannot manage in your setting, so give Maxelf, give antihypertensive, either lobetalol or nifedipine, steroid give if the gestational age is less than 37 weeks, and transfer with attendance and monitoring and a one attendant, and who have the eclampsia kit with the additional dose of Maxelf and the oxygen and the mouth gag, so that if fit come or something complication happen, the patient is dealt in the ambulance also, and no sublingual nifedipine. Last few slide about intranatal care, what it is about life your birth chart. हमारे जो decision है वो उसका horoscope fetus का बनाने वाले हैं. So this is very important, and what we say termination is good for mother, but it is many times not good for baby. So this is very important that when you choose expectant treatment, even for 1 to 2 weeks, you should be very sure that you are not increasing the maternal risk. Broad outline, if the patient is having mild feature around 37 weeks, but if they come to 37 weeks, even it is a mild category or mild manifestation, don't go beyond 37 weeks, but terminate if there is a platelet count, organ dysfunction is there in either mother or all the fetus. So the induction of labor at 36 weeks, it is like very fair for the majority of the patient which we have dealt. This I have already told. Now this is important. Again, I say if it is absent umbilical artery flow, not go more than 34 weeks, and if it is reverse, don't go more than 30 weeks. If in 30 weeks you are finding reverse and diastolic flow, don't wait for it, because in utero also it is not going to work. Fetus is not going to have any advantage. Steroid priming is there. We have to do it. Multiple dose, not even one rescue dose is fine. Maxelf for neuroprotection, it is also important, and today we are switching much readily to the cesarean section, and the evidence also says that around there is a high probability chance if it is removed then from that term. So this is important that we should have a low threshold for cesarean section, especially when there is a fetal growth restriction or the fetal compromise or the mother's monitoring is there. Fluid balance, never over fluid. It is 60 to 80 ml per hour. It is very, very important. Anesthesia, GA carries more risk than the spinal and the epidural. Only the exception is when there is a platelet count low or there is coagulopathy. So PPH fluid, and if we need that the blood transfusion or the frozen this blood component. This I'm saying, and the postpartum care, I think my time is up. That we have to be very, very careful in postpartum period. I really, all of will experience that on third day, on second day, after 36 to 48 hours of delivery, patient develops suddenly fit, patient develops suddenly ARDS, patient develops suddenly pulmonary edema. And why? Because we give certain fluid, we give oxytocin, there are a pain related to delivery, and that is the most important period where we should be careful in the immediate postpartum period. Very, very close vigilance is needed in postpartum period. If you want to taper the antihypertensive drug, do start from the third or fourth day. Don't discharge them before fifth day. NSAID is a big question mark. Some say it is okay, and some say that we should give the opium opioid for the pain. Short-term monitoring, call him after 7 days, then after 3 months that the persistent proteinuria hypertension is not there, and never lose the patient for the long-term contraception. What is the next risk of preeclampsia and SGA in the next pregnancy, and long-term gestational, long-term essential hypertension and the metabolic disorder. So life is full cycle. Pregnancy tests women health at many fronts, and it gives warning what is happening to this woman in future. And as an obstetrician, we are fortunate to intervene lifestyle and medical intervention at young age, and our decision and management is affecting short-term, long-term health, mother and the generation next. So thanks for always being together. Let's devote time, treasure, and talent. Surakshit Matra, Dr. Saroj Singh, Dr. Preeti, and everybody, Dr. Usha Sharma, guidance for Dr. Manju Verma, who are the teachers of teachers, and like they have inculcated that hard work, that keenness for the knowledge and skill to us. And with this, I seek your full-hearted support for my presidential candidature. World need diversity. Today, voice is for the democracy, for the diversity, for everybody's voice and experience. We have to be confident and we have to play our role in our professional organization for the benefit of women and the family of our country. Thank you very much.
So thank you, ma'am. That was really truly enhancing for this. Thank you so much for this vivid and extensive talk. I now request respected Manju Verma ma'am to please put forward the salient points and conclude the session.
Before I put on the salient points, I would like to repeat again that I will request everybody to support and vote for Dr. Sadhana Gupta, who is contesting the election for president. We all know she has herself also. She is a confident person. She has got leadership qualities. She is compassionate. She has got all the qualities, and I think I will request all of you to vote for the principles, not for the person, but vote for the principles. So that is how I would like to say that Dr. Sadhana to be supported and voted for. Coming on to the subject itself, I think she has been very nicely elaborated all the points. I would just like to repeat the salient ones that as far as the definition goes, we all know that it is the hypertension, severe 160 over 100 or more, with associated with one or more factors which are associated with it. There are a list of 5 or 6 factors like proteinuria, like oliguria, cerebral edema, symptoms like visual symptoms and pulmonary edema, then quantitative assessment of protein in the urine, impaired liver function, and which means severe hypertension is defined as a syndrome which has got severe preeclampsia as a syndrome which is defined as severe hypertension and or symptoms and or with biochemical or hematological impairment. So we coming on to the management principles, she has already very nicely described. The basic principles are basically to control hypertension, to be less than 150 and less than 100. That should be the motto. Then make self regime to prevent seizures and plan the delivery when, how, and where. There are indications for conservative management and there are indications for immediate termination of pregnancy. So I won't go into the details of that, but very, very nicely, given a talk regarding the severe preeclampsia and eclampsia. Very elaborate. Congratulations again, Sadhana. And I would again request everybody to vote and support for you. Thank you very much.
Thank you.
Congratulations, Dr. Sadhana. I was just called from Mr. So I just want to leave and congratulations again and again. One thing I just wanted to clarify, like I read somewhere, not today, there's AACG guidelines for the blood pressure. If the patient is normotensive, this should be 130 or 80 or 90, we should be alert.
Actually, Tarini, there is a lot of diversity, and actually the ISHHP, what is the Lelsey Regan, that is a landmark paper that they say that it should not be 140 by 90. We can start antihypertensive at 130 by 85. They have a particular 130 by 85 because if we don't treat that, the more patients come with the high rise, with the severe hypertension. So it is a ISHHP. I have also said that because they don't want that they should be differentiated between the severe and mild form, because the people get confused and people take it lightly. It is 130 by 85. It is not ACOG. ACOG, they are the Western and the developed world is comfortable with even 150, 90.
No, it's written somewhere ACOG 17 something. So they say that we should start a baby aspirin
and
at this
level.
Yes.
And just our chapter says that it is 140/90, and this thing, I think it is quite reasonable that at 140/90 we should start antihypertensive. And if I will say
They are saying
no,
it should start
anti-hypertension.
aspirin.
Aspirin is a little like it is in a different like no, it is
Yeah.
for the this.
तारनी जी,
like,
तारनी
it
जी,
is
आप
like
please
something.
To clarify,
तारनी
what
जी,
is
मेरा
Prevention.
पैनल, मेरा
Extended.
पैनल, मेरा
हाँ,
पैनल
I would
डिस्कस
like to
हो रहा है.
add one thing here.
okay,
I would like
and
मेरा
one thing
पैनल
more,
डिस्कस हो रहा है. नहीं नहीं नहीं,
one
मेरा
thing
पैनल
more, how
डिस्कस हो
much
रहा
is the
है.
role
Yes.
of these
तारनी जी,
biochemical
आपको रुकना पड़ेगा.
factor,
तारनी जी,
Papa, panel, no, doctor,
Prevention,
Dr.
prevention,
Preeti,
prevention
actually,
बताइए.
तारनी जी
Dr. Preeti,
एक point.
Dr. Preeti, chalo, I will ask you on phone. Actually, I have got a call from SR office. I have to attend there and to go somewhere. So I'm sorry. So I'm leaving Dr. Sadhna and Dr.
Thank you.
Preeti. I'm sorry. I will ask you on the phone. And thank you, everyone. Congratulations to
One
this Dr. Saroj Singh.
One point I
And
would like
all
to
the
add
best.
here is, one point
Yeah.
I would like to add here is that there is a concept of ICU and HDU attached to labor room, and that should also
Okay.
be included as far as the management is concerned. HDU and ICU attached to the labor room. And we should share our responsibility
Yeah, thank you.
by a multidisciplinary approach rather than taking all the responsibilities on our side.
But sometimes we have to take the responsibility, most of the time it's not possible for everyone to have these. You are right, but practically in India, it's a little bit difficult.
1% show.
Both are correct, madam, because we sometimes we have to take the risk because we have to save life. And madam has said that the today's scenario is because once upon a time in my single person I used to need so many eclampsia, but not now because it is a multidisciplinary and ICU.
That's true. That's true.
Dr.
That's
Saroj
true.
Singh is the she is dealing with so many of eclampsia all referred, so her experience.
Everyone has so many experiences with this problem, so I think
हम लोग के टाइम में तो बहुत आते थे, बहुत।
नहीं मैडम, अभी भी बहुत हैं, बहुत हैं,
हाँ,
अभी भी
पर
बहुत
फिर भी पहले से जरूर थोड़ा कम है।
Dr. Saroj, sorry,
हाँ जी,
नमस्कार मंजू जी मैडम।
प्रीति जो है बिल्कुल बेसबर हो रही है,
बेसबर ना हो,
उसका टाइम जा रहा है।
मैं क्या कह रही हूँ, हम लोग की ड्यूटी में अगर 2-3 एक्लेम्पशन ना आए तो बड़ी लाइट ड्यूटी गई। बात तो बड़ी लाइट, और इतने भरे रहते थे सेप्टिक में कि पूछो मत।
बस मैडम एक अच्छी बात हुई है कि
हम लोग का जमाना,
जो गवर्नमेंट की ट्रेनिंग्स चल रही हैं उसमें PSC CSC वाले डॉक्टर्स को सेल्फ लगाना और लैबिपेट लगाना, हम लोग ना सिर्फ वर्बली सिखा रहे हैं, उनसे लगवा के देख रहे हैं, तो अब वो लोग लगा के भेज रहे हैं। ये फर्क हुआ है।
काफी क्रेडिट प्रीति को जाता है।
हम लोग भी बहुत सारी ट्रेनिंग्स कर रहे हैं उसकी,
हम लोग
उनको लगवा के सिखाते हैं और फिर वो वहां से जाके जब लगा के भेजते हैं तो देन देयर इज अ डिफरेंस।
बिल्कुल बिल्कुल बिल्कुल।
हम लोग ने ANM की
पैनल शुरू करा भाई,
ट्रेनिंग करी थी।
चलो भाई,
काफी डिस्कशन हो गया। अब नाउ वी हैव एन इंटरेस्टिंग पैनल लाइंड अप on clinical case discussions in preeclampsia, and to moderate the panel we have none other than our very dynamic Dr. Preeti Kumar ma'am, chairperson Safe Motherhood Committee and co-chair perinatal and maternal committee SAFOG. Welcome madam. To co-moderate the session, Dr. Anu Pathak, Professor, Department of Obs and Gynae, SN Medical College, Agra. And we have a list of esteemed panelists for this panel discussion. Professor Amrita Chaurasia, HOD, Prayagraj Medical College. Professor Nidhi Gupta, Professor in the Department of Obs and Gynae, SN Medical College, Agra. Professor Shikha Seth, HOD, GIMS, Greater Noida. Dr. Savita Tyagi ma'am, Secretary, Agra Obs and Gynae Society. And Dr. Rehana, HOD, Tirthankar Mahavir Medical College. So we all are waiting to hear from you. And the session is all yours now, Preeti ma'am. Please take over.
Can you stop? Yeah, thank you so much. I'm going to share my screen.
तो प्रीति नमस्कार, आपके लिए रुके थे नमस्ते करने के लिए।
ये गलत चीज है,
ठीक है,
गलत चीज है क्या?
करूंगी, ठीक है, फोन पर
तारनी जी रुकिए रहिए आप।
अच्छा प्रीति, गला ठीक हो गया?
कॉल अटेंड करनी है
मैम, अभी नहीं सही हुआ।
तो फिर
ये सब जो है सब चक्कर में फंसेंगे धीरे धीरे, क्या करो।
कम बोलना, कम बोलना।
मैम कम बोलेंगे।
बहुत बोलना मैडम, प्रीति दी से तो हमें सुनना।
नहीं यार, उसका गला खराब है
आज
बेचारे
मेरा
का।
गला खराब है।
कोई बात नहीं,
और
इन लोगों को
माशा,
आदत है।
अम्माओं को तो फिक्र करनी पड़ती है ना, फिर क्या करें।
हाँ. So good evening everyone. Pranam to Dr. Usha Sharma ma'am, Dr. Manju Shukla, Dr. Manju Verma, and thank you Dr. Saroj madam for inviting me here and giving me this prestigious platform. So after listening to Dr. Sadhna ma'am's talk, wonderful deliberation on severe preeclampsia, we will take you all to the other spectrum of the disease, probably how we can just prevent it, because the topic for this session was preeclampsia, what is new. So Dr. Kirti Dubey was supposed to join as an expert. We have Dr. Saroj Singh ji as an expert, but ma'am could not join because of some her personal problems. So we can have Dr. Sadhna and Dr. Manju Verma ma'am, and also we have other seniors also. They can give their comments on any of the issues. So myself, Dr. Preeti and Anu will be moderating this panel. I'm extremely sorry for my bad throat, but still I'll try to do my best. We have galaxy of learned panelists here, Dr. Amrita Chaurasia, Shikha Said, Nidhi Gupta, Savita Tyagi, and Rehana Nazm. And I just want to tell you all that we have 40 minutes today, and let your answers be very crisp and concise. We will talk more on the experiences. We will more on talk about the knowledge, attitude, and practices in our country, rather than what is being done in the Western world. So just quickly defining what preeclampsia is. Lot has been spoken. Preeclampsia
Your screen, Preeti.
Is it not visible?
No, your screen is not visible, ma'am.
Okay. Is it visible now?
No.
No, ma'am.
I'll share again. हाँ. नहीं तो हमने मिनिमाइज करके रखी है पीपीटी. विजिबल है ये?
नहीं, उसे फुल स्क्रीन करिए.
नहीं है.
नहीं, स्क्रीन विजिबल है मेरी कि नहीं विजिबल?
नहीं, कुछ भी नहीं आ रहा अभी.
आ रही है,
प्लेन आ रहा है बिल्कुल.
अच्छा. हाँ
मैम, हाँ फिर रीस्टार्ट कीजिए.
हाँ.
मैम जैसे आप शेयर स्क्रीन पे करते हो ना, तो आपका विंडो पे सब प्रेजेंटेशन और स्क्रीन दिख रहा होगा.
हाँ.
और जो वो सारे विंडो में से जो आपका प्रेजेंटेशन है ना, उसको सिलेक्ट करके फिर शेयर कीजिए.
अच्छा.
मैम मिनिमाइज नहीं करिए उसको. मैम
हमने मिनिमाइज किया उसको.
नहीं मैम, उसको खोल दीजिए. नहीं, खोल दीजिए मैम.
जस्ट होल्ड ऑन.
हाँ.
ओपन किया इसको हमने.
ओपन किया मैम.
हाँ किया. ऊपर बेसिक, एडवांस एंड फाइल्स आ रहा है, प्रीएक्लेम्सिया आ रहा है.
प्रीएक्लेम्सिया को
क्लिक करो.
हाँ, अब आया
मैम.
अब इस वाले को क्लिक करिए. जो प्रीएक्लेम्सिया नीचे है उसको क्लिक करिए. हाँ,
ये तो उनका है.
अब आया?
अभी नहीं आया. अभी तो वो अभी खुला नहीं है.
मैम प्रीक्लैम्सिया को क्लिक करिए. प्रीक्लैम्सिया यूपीसीओजी
जो नीचे बना हुआ है.
जो नीचे बना हुआ है.
मैम वो प्रेजेंटेशन ओपन है या नहीं है?
हाँ ओपन है.
ओपन है ना, तो हाँ आपका ये वाला स्क्रीन शेयर हो गया, आप बैक कीजिए इसे।
स्टॉप
ये
शेयर
स्क्रीन,
करें?
हाँ स्टॉप शेयर कीजिए।
हाँ किया।
अभी शेयर पे क्लिक कीजिए, शेयर स्क्रीन पे।
हाँ किया।
और वहां पे विंडो में आपका प्रेजेंटेशन दिख रहा है कोई एक?
हाँ दिख रहा है।
वो विंडो पे, वो आपके प्रेजेंटेशन पे क्लिक करके फिर शेयर कीजिए।
हाँ अब आ गया,
आ
आ
गया
गया।
मैम।
अब विजिबल है?
हाँ जी।
हाँ जी।
Okay, so we'll carry on from here. Preeclampsia is defined as gestational hypertension accompanied by more than one of the following new onset conditions at or after 20 weeks of gestation. Lot has been talked about proteinuria, but we'll take some of the discussions on proteinuria and any of the symptoms or end organ dysfunction or uteroplacental dysfunction. FIGO and International Society of Hypertension take uteroplacental dysfunction or fetal growth restriction or any form of abnormal umbilical Doppler waveform or stillbirth also as one of the criteria for preeclampsia. Now I'll request Anu to take up the first case now. Anu, can you read the first case?
Yeah, ma'am. Thank you, ma'am. We are having a Mrs. S, age 32 years, obese, with married life of 8 years. She is gravida, IVF conception. She is a well-booked case. Her blood pressure at 36 weeks of pregnancy, her blood pressure was 140/90 millimeters of mercury. And her previous ultrasound details shows at 12 weeks, she was having biochemical markers was done at 12 weeks of gestation. Free beta HCG was 0.8 multiple of median. PAP-A was in the range of 0.5 multiple of median. Uterine artery mean facility index was 2.8. The patient was screen negative for aneuploidies and high risk for preeclampsia. Her anomaly scan was not having any abnormalities. Her present investigations are showing hemoglobin 10.4, PCV 31.8%, WBC count is 9,980. Platelet are 1,63,000. LFT was within normal limits. Urine albumin was nil. Creatinine was 0.6 milligram per deciliter. Uric acid was 3.3 milligram per deciliter. APTT was 26.2. PT was 13.5 seconds. And INR was 1.17. Now,
coming to the first question to Dr. Amrita Chaurasia. Amrita, what would be your diagnosis in this case?
Thank you, the organizing team, for involving me in the panel. The diagnosis, like you have said, she's not having proteinuria, she's not having any feature of the end organ damage. And I guess the blood pressure has been taken twice, at least 4 to 6. She's having 140/90 millimeters of mercury. So she seems to be a case of gestational hypertension. She is not yet preeclampsia because, as Sadhna ma'am has also said, for preeclampsia, there has to be either proteinuria or the presence of any of the end organ damage, starting from the brain, eyes, lungs, liver, and kidney.
Okay, so rightly said, Amrita, it could be a gestational hypertension because it is defined as a systolic blood pressure of more than 140 and a diastolic of more than 90, at least 2 occasions apart, 4 hours apart, developing after 20 weeks of gestation. Now, Amrita, my question would be, how significant is gestational hypertension when we talk about the hypertensive disorders in pregnancy or in reference to preeclampsia?
Yeah, see, gestational hypertension should also be not ignored and taken lightly because anytime, since this PET is a progressive disorder since till the patient delivers. So we must have a careful watch because anytime she can progress into preeclampsia and she can directly progress to eclampsia as well. So we will have to take a proper check and we will have to keep her under a strict antenatal coverage and we will have to do all the investigations like CBC to see for the platelet count and liver function test, kidney function test accordingly. At least in this patient, she is having only gestational hypertension and having all the normal parameters. So we would have weekly checkup of all these investigations.
So Amrita, my again next question would be, suppose if she would have come earlier in pregnancy, maybe around 24 weeks or 26 weeks or 28 weeks, and she had this gestational hypertension, would your monitoring be similar to preeclampsia or would it differ from preeclampsia?
No, we will have to make it more frequent monitoring of the patient. Like in a non-high-risk patient, we call the patient till 28 weeks at monthly interval. But in this patient, we would like to call her at more frequent intervals, like at 15 days interval. And at any point of time, we will also counsel her regarding the development of warning signs. If she develops headache, if she develops blurring or in disturbed sleep, she will have to report immediately. So that way we will, yes.
Okay, so I think I think what I could get from
positive, so she must have.
We are not. No. I just want to have a take home from this platform that all pregnant women who develop gestational hypertension should be monitored similar to preeclampsia, because they have a very, very high chance of developing preeclampsia. Am I right, Amrita? This is what is the first take home message from here. Gestational hypertension should not be considered lightly, because they have equal chances of maternal and neonatal adverse outcome as compared to preeclampsia. Now coming to Shikha, now next question to Shikha is, what is white coat hypertension and what are
I want to add one thing to this patient.
Yes, please.
Dr. Savita from Agra.
Yes,
good evening, ma'am. Ma'am, because this patient is having this uterine artery pulsatility index on higher side and mom are also low. So chances of development of PET are 41% in this patient. So we should closely watch this patient. Some factors are there in first visit when we did the uterine artery pulsatility index in first trimester, and mom of this PAPE and this plasma factor, then these were lower side. And these were in favor of development of preeclampsia in this patient.
Yes, rightly said, Savita. We'll take up these questions a little bit later on. So we just want to take it step by step. So now next question to Dr. Shikha is, what is white coat hypertension? We talk about, I think Dr. Sadhna ji also mentioned about this white coat hypertension in her presentation. What is white coat hypertension and what are its clinical implications? Shikha, can you take up this question?
Yes, ma'am. White coat hypertension, as we all know, is the hypertension when the patient comes to the hospital and the doctor, in the doctor's clinic, if the blood pressure was found to be higher, and when we say that you should monitor it at home, and when she monitors at home, it is not that in the hypertensive range. So whenever in the hospital setting, in the clinics, we come across a high blood pressure range, and on routine home monitoring, she doesn't find that kind of an hypertensive range.
Shikha, how significant it is in a clinical practice? Because most of the times we find that whenever the patient is there in the chamber, her blood pressure is more. And when we take it after some time, it becomes normal. So should we mention it on the paper, or how would you counsel, or how would you see this patient as far as the advenatal journey is concerned?
As such, it's a thing like people have a different ideas about this white coat hypertension. But if sometimes anytime the patient has been taken the blood pressure correctly, whatever the guidelines says that in the clinic she's sat for 5-10 minutes and then calmly we have taken the blood pressure, and if the blood pressure has come out raised, I think it should be mentioned in the paper, and she should be asked to monitor the blood pressure at home regularly. And this should be taken as, I feel that this should be taken as a factor that she may land up later into this kind of some hypertensive, especially if it is in pregnancy. It should be considered as a risk factor.
That's right.
If any time
Shikha, would you like to counsel right at that point of time to pregnant women that, see, your blood pressure is a little bit higher, maybe the first reading, but you might, how much is the chances of developing preeclampsia in these?
I think, ma'am, exactly I cannot say it is the percentage, but even at the once it has come up raised, and as with the increasing gestational age, definitely the chances is going to increase in the blood pressure. And once it has come up raised in any of the findings, whether at home or at a clinic, it is a factor which is going to affect and must be considered and counseled that this is the condition and she should be more vigilant, and her gynec also has to be more vigilant for the monitoring.
So again, the purpose of this putting it up is that any kind of gestational hypertension or maybe white coat hypertension, these are very, very relevant and you should not miss them or ignore them because they have very, very high chances of having preeclampsia, and more so when they have more comorbid conditions like obesity or maybe diabetes, they have more chances of having hypertension. So Dr. Nidhi, now next question would be to you. What are high risk factors in this case?
Thank you, ma'am. Thank you, Preeti, ma'am. The high risk factors, number one is her age, 32 years.
Yes.
The second is her obesity, which is a very high risk factor again. And the third is that she has taken IVF treatment. These are three high risk factors from her history. And rightly stated by Dr. Sabita that her PI at the first ET scan was high as 2.8. So taking these things into consideration with a lower mom for HCG, and I think she is a candidate where her risk factors for preeclampsia are high.
Yeah, primary gravida is also one of the
sorry, ma'am, primary gravida also.
Again, anything
and then elderly primary primary gravida with obesity, with a married life of 8 years. She has conceived after 8.
So any of the worthy panelists would like to add anything regarding the IVF conception? Anything new you want to add in this?
Ma'am, they have stated that IVF conception is a risk factor nowadays, except for IUI pregnancies. It is a risk factor for preeclampsia, which has come in the gestosis risk coding, that IVF conception, except for IUI, will be taken as a risk factor for developing preeclampsia.
Yeah, and more so when you use a donor sperm, sites, they have a very, very high chances of developing this thing. Now, Anu, can you take up these questions now?
Yes, ma'am. Sure, ma'am. Now, how should the blood pressure be measured during pregnancy? Savita, madam,
yes,
please.
Yes, as soon as
like to answer
to us for the antenatal visit, we should measure the blood pressure of the patient. Best is to measure with the sphygmomanometer, but because nowadays we cannot use these BP instruments. So second thing is the patient should be sit in the proper comfortably, and the arm should the BP instrument should be at the level of the heart of the patient, and it should be supported. Arm should be supported, and cup should be appropriate size adult cup should be used, and we should give the rest of at least 5 to 10 minutes to the patient, so patient becomes comfortable. Then only we should measure the blood pressure, and at least we should use 2 sets of recording should be done, and it should be the gap of 1 to 2 minutes interval, and we have to measure the 4 sets of the systolic blood pressure and diastolic blood pressure measurement needed for input into the risk calculator. Final mean arterial pressure measurement should also be done, and it will be automatically calculated.
Okay, thank you, ma'am.
Okay, so
Dr. Anu, can I add?
Hanji, ma'am. Sure, ma'am. Sure.
Who is there?
Ma'am,
Nidhi, madam is saying.
Ma'am, if you would like to add, I would like to add.
Nidhi, I just wanted to ask Amrita, because this is very relevant. Actually, Sadhna ji, when she was giving her talk, she said Preeti will talk about the blood pressure measurement. Now, Amrita, you are sitting in a tertiary center, maybe Saroj ji is sitting in a tertiary center. How many times you take mean arterial pressure, or how many times you take 4 sittings, 4 readings?
True, ma'am.
Yes, ma'am. We usually don't take.
So we'll have a word from Saroj ji, and we'll have the word from Amrita also. How significant is that when we talk about the mean arterial pressure, or when we talk about the 4 sittings of blood pressure?
Although, yes, Dr. Preeti, you have very rightly said that practically in routine taking mean arterial pressure, routinely it is not being done. And ideally we should do it, because FIGO has also given it in its screening guidelines, and where we are not able to measure biochemical markers or routine color Doppler at 12 weeks, it is mean arterial pressure becomes a very good factor which we should do, and we should bring it in our practice. One thing more which I want to add, that now NMC has also guided that we should use digital blood pressure instruments
Yes.
instead of the mercury, because to prevent the person-to-person variation in taking the blood pressure.
Yes.
So they should be preferred, because the standard and very good digital BP instruments we have, that also we should be preferred to giving to the health workers and all that. And mean arterial pressure should come ideally in.
Yes, I think it should come, Sarojji, because even all the cardiac associations, all the cardiology people, they talk about more about the mean arterial pressure. And let me tell you, mean arterial pressure gives you the best indicator for the vascular mortality and morbidity. So this should be better. This would be the best predictor as far as the systolic or diastolic blood pressures are concerned. And you can simply calculate by a very simple formula, that is diastolic blood pressure plus 1/3 of pulse pressure. So this is how we calculate the mean arterial pressure. And the normal is between 70 to 100, but should be kept below 85.
It's very important. Very important.
So next, Anu, take up the
If you allow, I just want to add one thing.
Yes.
The posture of the patient is very important. The legs should not be crossed, and legs should not hang from the chair.
Yes.
And because nowadays we are using more of the electronic devices. So I think every month or every 3 to 4 weekly, we should calibrate our instrument.
Yes, that's true.
With the normal mercury or.
Yes, that's true. So Anu, can you take up?
What is the significance of proteinuria and what are its implications in the current scenario? Dr. Rehana, nurse madam.
So, Rehana, we would like to have two answers from you. Number one is what Sadhna ji mentioned. Yes, you have to check proteinuria. Number one. Number two is, would you like to recheck it again once you diagnose that she is already having proteinuria? Would you like to reconfirm again in the next readings? Or any severity of proteinuria, does it in any way affect the maternal and fetal outcome? So there are three questions to you. One is how you check proteinuria, whether it is a PCR ratio that you're doing, or you're doing a heuristics test, or you're doing a 24-hour urine collection test, because you are also in a tertiary center. Number two is, do you recheck it again? Number three is, does the quantification of proteinuria affect the maternal and the fetal outcome? So there are three questions that we really want to put here as far as the proteinuria is concerned.
See, first thing is that proteinuria, normally we do the dipstick test, or in our PG time, usually we used to do with the test tube and all that, but nowadays we are doing dipstick test.
Most of us we are doing.
Yeah, we are doing with that. And definitely the severity, the increase in the proteinuria is going to reflect the severity of the disease. This is for sure. So if a patient like she has come to us in the initial visit, we'll monitor her blood pressure, we'll do her urine dipstick test, and suppose it was 140/90 blood pressure, urine dipstick at that time was traces or it was not there. Then subsequently, again, when she will come, say after 2 weeks, it has to be done again in the outpatient department, because it may change. Like even ISSHP is saying, even ACOG, even RCOG, they say that when the patient is coming again for her subsequent visit, we should do her urine protein estimation, and we must monitor her renal function test, her kidney, this liver function test, and depending upon the fetal parameters, we must do her ultrasound for fetal biometry and all that.
Okay, Manju ma'am.
Regarding 24-hour urinary protein estimation, that nowadays, as per the latest guidelines, it is not being recommended. Although it is being said by RCOG says that it may vary in the daytime. The point test which we are doing, it may vary. So they are saying you should do a 24-hour estimation. So that we can do in the initially when we are admitting the patient, or if the patient is very severe and it is possible, then
so
we
Rehana,
can.
My question is not we can do. What you are doing in your practice, that is my question. And Manju ma'am, would you like to add anything here?
I would simply like to add here is that this collection of sample has to be very, very carefully done, because unless the person cleans the vaginal secretions, because once the vaginal secretions are mixed up, the protein is going to be there in the urine. So that is one precaution that one should take.
And 1+ or more, if it is there, I think it is clearly
yeah. So proteinuria during pregnancy is defined
Dr.
as
Preeti,
more than,
can I
yes,
say something?
Saroj, yes, ma'am. Sarojji.
Dr. Preeti?
Yes, ma'am.
What I know that the 24-hour collection is no more indicated now.
Yes.
Because it's once we have diagnosed that it is 2+, it is severe preeclampsia. For that it's enough. There is no need to do it repeatedly because the level of severity is not correlated well with that. And we have to do other markers, other organs like platelet count and all that we have to do. And second important thing is proteinuria is not an essential thing for diagnosing preeclampsia. That we have to remember very nicely.
So Sarojji, I think when we talk about two people who are practicing in Metropolitan, they do PCR, but we as routinely do dipstick for protein test, and we are not doing 24-hour urine collection. Now, Anu, can you read it out, this one? Anu?
Yeah, ma'am. Following the initial documentation of proteinuria and the establishment of the diagnosis of preeclampsia, additional quantifications of proteinuria are no longer necessary according to ACOG 2020. Although the amount of proteinuria is expected to increase over time with expected management, this change is not predictive of perinatal outcome and should not influence the management of preeclampsia.
So this is the take home from this point, that you can do proteinuria testing, but once it is diagnosed, you need not to repeat it again. It is in no way going to affect the perinatal outcome in any way. This is the ACOG recommendation. Now, coming back to Amrita, what are the screening tests available? We talk about the severity of preeclampsia, so much of maternal mortality and neonatal mortality and morbidity involved. So what are the screening tests available in our country, and actually what we are practicing? Any new test which is there? What are the clinical implications of these tests? Amrita, the question is to you.
Yes. See, Preeti ji, the thing that we are practicing, actually, we are doing the clinical risk scoring, that is Gestosis score. And they have given 3 kind of risk factors: mild, moderate, and severe. The mild one is having 1 score, moderate is having 2 score, and severe is having 3 score. And that is very well available on the Google. So if any of the patient is having 3 or more than 3 scores, she seems to be screen positive. And from there only we start the preventive therapy.
So Amrita, my question again, I'll stop you here. There are 2 words, screening and prediction.
Yeah.
Now you have 2 words, separate words, screening and prediction. Can you just define these 2 words? What do you understand by screening, and what would you do when you predict, how you predict?
Yes, the screening is, it is applied on the mass. Irrespective of the presence of risk factor, we screen the universal, all the antenatal patients who are coming for the first time in the first trimester. And that is how we screen. And prediction is only in those patients who comes to be screen positive. So that is why we take there. And apart from the Gestosis score, we have certain tests, like we have already talked about the mean arterial pressure, that we can very easily we can do it with a easy formula. And apart from that, some biochemical and radiological markers are also there. If we are lucky to have, we can have her biochemical PLGF and double marker test. And apart from that, we can have her uterine artery PI value. So almost like now, all of us are having aneuploidy screening at 11 to 13 plus 6 days. So we can have uterine artery PI at that time. And we have already talked about the MVP. So with all these combined tests, we can predict up to 75% of the patients who are going to develop early preeclampsia.
So Amrita, I would say, in the other words, that in your hospital, you are basically predicting on the basis of Gestosis score.
No, in our hospital, it's a tertiary hospital with a high load. So we are trying to do Gestosis scoring in the patients. And we are trying to do it almost in the 100% of the patients, and we are doing it also. But getting this thing, uterine artery PI, and getting these biochemical markers, it is not universally acceptable because they are having higher costs. But if we can have, they are definitely going to help us.
So other panelists, would you like to add something, or is anyone who is practicing in a different way in their setup? Rihana, Savita, or Nidhi?
Ma'am, we are going for this uterine artery PI index and double marker between the 11 to 13 weeks in each patient of our clinic, because we are the private. I am the private practitioner.
Okay,
we are going for. I am going for that, and at the same time, we can come to know whether this patient is having the high risk for the preeclampsia. Along with these tests, we also see if patient is having high BMI or she is a case of diabetes, history of a previous history of eclampsia or diabetes mellitus. Just in the, if she is having any higher risk factor along with this, we usually start the aspirin in such cases if patient is having the high risk.
Okay,
for the high risk.
So what I could get is most of us are doing gestosis score as far as possible. But if possible, we are doing the uterine artery PI, and depending on whether the patient is affordable or not, she can afford or not. And then we start the low dose aspirin or whatever prevention protocol. So Saroji, your take on this, we have several these things because we need to just find out the patient specific risk or priori risk based on the Bayes theorem. And we need to find out whether this pregnant woman is at a risk of developing preeclampsia.
Although FIGO has suggested universal screening for all, that means all four things, that is high risk scoring, mean arterial pressure, and pulsatility index, as well as placental growth factor. But practically speaking, when sitting at a tertiary center in a public sector, it's very difficult to do it. Yeah. Very difficult. So practically, what I think that doing gestosis score as well as MAP should be for all, and those who are high risk, they should be subjected to uterine pulsatility index and
biochemical markers.
Cannot be done for every patient. It is
Anu, can you just read out these gestosis score here?
Okay, ma'am. Just to summarize, in gestosis scoring, we are having some risk factors and we are doing scoring for them. So mild factors that are having score 1 are women born is small for gestational age, maternal anemia, age older than 35 years, patients having age, younger patients having age less than 19 years, obesity, patients having BMI more than 30, nulli gravida, shorter duration of paternity, family history of preeclampsia, family history of cardiovascular diseases, patients having polycystic ovarian syndrome, intra-pregnancy interval less than 5 years, pregnancy as a result of artificial assisted reproductive treatment, IVF, history of IVF or ICSI, maternal hypothyroidism. These factors are giving one. Also, chronic vascular diseases, excessive weight gain during pregnancy, mean arterial pressure more than 85. These things are having score 1. Other things that are having score 2 are cases having history of gestational diabetes, obese patients, BMI more than 40, multiple pregnancy, hypertensive disease during previous pregnancy in the cases having this history. The conditions that are giving score 3 are pre-gestational diabetes, chronic hypertension, mental disorders, inherited or acquired thrombophilias, history of maternal chronic kidney disease, history of autoimmune diseases, or assisted reproductive treatment. History of these factors are giving 3 score. Points 1 and 3 are allotted as per association risk factor. If the total score is more than equal to or more than 3, the pregnant women should be marked as at risk of preeclampsia. And these cases, we have to start preventive measures in the form of low dose aspirin and calcium, etc.
So, as rightly said by Saroji, we have the combined test. The best model is one that combines maternal risk factors, mean arterial pressure, PLGF, and uterine artery pulsatility index. So these are the 4 parameters that should be tested, and this is recommended by, again, FIGO. And ideally, these should be done. Universal screening should be offered to all pregnant women, and the risk patients should be calculated by maternal risk factors. Now, Shika, coming to you.
What we have made a flexi chart of this gestosis score, and we have put in the OPD, ANC OPD.
Okay, so I think, Amrita, I think still the gestosis score is not validated, but I think this is the best thing that we can do in the that we can offer to our pregnant women. So coming to Shikha, she went through a screening test. The first case, she was screen positive, and yes, she developed hypertension and not preeclampsia. What does that mean, and what is screen positive? Shikha?
Yes, ma'am. Screen positive basically means that whenever we have whatever the combination of screening tests we have done, like mean arterial pressure or gestation, patient's age and PI values, whatever the things has been done. So if it has come out to be positive, it means that she's screen positive, but does not mean that all screen positive will definitely go into a preeclampsia, they develop preeclampsia, something like that. But yes, of course, they have a high tendency and they should be monitored more frequently and they should be warned for that test. And then the screening also has to be done. Firstly, we just do it at around first trimester, whenever the patient comes, and based on these factors on history basis, we screen them out. And later on in the second stage, we can screen with placental growth factor and uterine artery PI. This is again a main screening strategies which is nowadays being used.
Okay. So thank you so much, Shikha. I'll quickly summarize. This is a recommendation that is given by FIGO. You can do screening in 2 stages. First is screen by maternal factors and mean arterial pressure, and try to find out the screen positive pregnant women. And those who are positive, you can offer them uterine artery PI or biochemical markers, and again predict whether this pregnant woman has a high risk of preeclampsia. Now, what my question was, when you say screen positive, is that when you take up these 4 factors, and ideally it should be offered between 11 to 13 weeks, 6 days plus weeks gestation. And screen positive is when the incidence is more than 1 in 100. That means out of 100 pregnant women, if she has a risk of 1 pregnant will be having the high risk of preeclampsia, that is a screen positive. Even then, 99 would not develop preeclampsia. So this was my question, that when you say screen positive, that is, it is more than 1 in 100, and these are at risk, and then you have to start the aspirin as early as possible in these. Now, Kirti ji is not here. We'll take up the question to Dr. Nidhi again. Now, we talk about the prevention. We know about aspirin. We know about the calcium high dose. Now, my question straight away would be, what is the dose of aspirin that you're using, when you are starting this aspirin, and when you stop giving aspirin?
Madam, I am starting aspirin as in a normal BMI patient at 75 milligrams per day at night. Whenever the patient comes to us, the best is to start before 16 weeks. And now lately, the recommendation is before 12 weeks. Okay. And it is continued up to 2 days before she goes for delivery or elective cesarean section. And in a high BMI patient, I take up the aspirin to as high as 150 milligrams per day.
Okay.
As regards the calcium intake, especially in women who are actually low in calcium intake, less than 600 milligram per day, I preferably give 2 gram of calcium, advise them 2 gram of calcium as soon as possible throughout pregnancy, even after she delivers.
Okay, so quickly answers from all the panelists, because we'll move ahead fast because we have less time. Yeah. Amrita, your take on aspirin, and then final comments from experts. Your take on aspirin, when you start, when you stop, and dose.
Ma'am, start if she's screen positive, we start around 12 weeks, and basically before 16 weeks it is more useful. But if we have not started, it can be started up to 20 weeks as well, as the recommendations say. And regarding the dose, the recommendations say 150 milligrams, some say 75 milligrams, some say 81 milligrams.
So your practice, Amrita, you talk about what you are doing in your center.
Like Dr. Didi said, if she is thin, less BMI, we start 75, otherwise we give 150 milligrams.
Okay, Savita, your take on this, and then Shikha, and then Rihanna.
Yes, I start in first trimester between 11 to 13 weeks, and I always give 150 to all patients, whether
and when you stop,
at 36 to 36 weeks of the gestation.
36 weeks of gestation. Okay, Rihanna, your comments.
My is also the same. If the patient BMI is low, then usually I give 75 milligram. If the BMI is more, it is more than say 30, then 150 milligram. And usually I start at 11 weeks and continue till delivery. Say 48 hours prior to delivery, we usually stop.
Okay, I think all the panelists have answered. Now, Saroji, your comments on aspirin now.
I usually give after 12 weeks and 150 to all of them at night. 150.
Yeah.
And the
So
most recent ACOG
Yes.
2020 recommendation, they say 81 milligram. Again, they are.
So ACOG का recommendation पहले से है अमृता 81 milligram का, but that is not available. We have now switched over to after aspirin trial to 150 milligram. Anyway, the dose of aspirin is 2.5 milligram to 3 milligram per kg body weight. It should be started as soon as the pregnant woman is screened positive. And then how long to continue is again important thing that I really want to highlight here is that FIGO and International Society of Hypertension say that you should stop aspirin at 36 weeks, number one. Number two, if pregnant woman delivers or she develops premature rupture of membranes, or number three, if she develops preeclampsia. So if any of these happen, if she crosses 36 weeks, or if she develops preeclampsia, or she goes in labor, then you have to stop. Now, American College, they say that you can continue till delivery. But these are the recent recommendations of International Society of Hypertension, and FIGO recommends the same what is recommendation by International Society of Hypertension. In any way, even if it is a mild preeclampsia, we do not want pregnancy to continue after 37 weeks. We have to terminate at 37 weeks of gestation. So dilemmas in aspirin is that prophylactic aspirin may not be so effective in lowering the risk of preterm preeclampsia in patients of chronic hypertension. This is very, very important. And there is a low evidence to support there's low dose of aspirin for prevention of previous severe preeclampsia or small for gestational age neonates in multiple gestation. These are again very, very important things that we should know. Again, Saroji, another question. Suppose a pregnant woman, COVID is at a high risk. We know everybody is suffering from. I'm also having a bad throat. I've sent the test today. Now, if a pregnant woman during the periconceptional period or in the first trimester develops COVID, now can we take it as the sole risk factor for starting aspirin? Or should we not? Because COVID is again linked to preeclampsia. Patients who have suffered from COVID have a high risk of preeclampsia. So can we consider it as a high risk?
Before telling the association of COVID with, because we all have been jailifying COVID for last more than 2 years. And what I found in our college also, out of 4 cases who we lost, 4 deaths which has occurred, 3 of them had severe preeclampsia along with COVID when they died. And what has been recently reported in American Journal, they have reported a detailed analysis of systematic analysis of multiple studies in which more than 15,000 COVID positive women were studied. And it has been found that there is a close correlation between the COVID and preeclampsia, because we see how COVID is entering our body. It is through ACE2 receptors. And again, then going endothelial damage and then increase in cytokines, interleukins, and ultimately causing microcoagulation and then causing the changes in D dimer and all that. And same things are happening in preeclampsia also. So basically, the basic mechanism is somehow they are doing the same thing. So that is the reason those cases who are having mild preeclampsia and develop COVID, they become very serious. And those who develop COVID in early part of pregnancy, they definitely become at high risk for preeclampsia. So they should be treated in the same way as the high screen positive type of cases. So we should start even aspirin if their platelets are normal and everything is normal. Okay. So they should be monitored at taking with the.
So we should start aspirin in these patients. That means
we should do the investigation because both have the same pathway to enter.
So, how much time we have for this panel? How much time is left? Meenal, can you just
Ma'am, time is over.
So I'll take just 5 minutes more. Savita, I'm skipping this question because a lot has been discussed by Sadhana ji. I'll take up the next case. I'll request Anu, because this is very important component. I'll take just 5 minutes more. So Anu, can you read out this?
Yes,
10 minutes more.
We are having Mrs. U. She is 26-year-old, second gravida, para 1, live 0. She presents at 31 weeks and she is currently normotensive. There is a history of severe PI 32 weeks and IUD in previous pregnancy due to abruptio placentae. So, knowing
Shikha. Yeah, go ahead, Anu.
Yeah, knowing her obstetric history, what intervention could have been done? Shikha, madam, Dr. Shikha Seth, ma'am.
Anji, ma'am.
Please.
Please just
Yeah.
So as she was having a history of IUD in previous pregnancy, especially due to abruptioplacentity, it is a case that is a high risk case of which has a very high tendency to develop at this. But at present, she is at 31 weeks and normotensive. Then I feel we should monitor her closely, get her admitted, do the primary basic analysis. And then continue to monitor as a usual protocol.
If Shika she would have come early in before conception, suppose.
Okay.
Would you like to investigate her for something?
Yes. If she has come earlier in the pregnancy, that definitely, because having a early severe preeclampsia, that too before 32 weeks, and have an IUD, it means she may be a case which has a high risk, like chronic disorders or autoimmune disorders, which we may have to take as antiphospholipid antibodies.
Yeah, that's very true. This is the point that I want to highlight here. That we have to
Ma'am, can I add? Ma'am,
Yes,
because
please.
she has two high risk factors now.
Yes,
She
yes.
has the previous PIH at 32 weeks, and she has again a high risk factor in this IUD. So we will have to tackle both of them. We cannot just talk of PIH and PIH. It is two things together in this.
Together,
patient.
yes,
So we
yes,
have,
yes.
We
So
have
right now she's
Yeah.
asymptomatic. She's coming to your antenatal clinic, and she has this history of 32 weeks previous PIH and IUD.
With IUD, yeah. Ma'am, if she's normotensive, then that gets off. But then IUD component in the previous pregnancy is there. So I think we have to...
Sarojji's comment. Yeah, Nidhi,
Yes.
thank you so much for your comment.
Although she is normotensive presently, but she is definitely at a high risk for developing preeclampsia very soon. So I will like to start aspirin after doing this, because although screening time has gone, but there are few things which we can study even at 31 weeks, like placental growth factors. We can study in its low level, and something like anti-angiogenic factors, biomarkers.
Roji, would you like to investigate her on the lines of preeclampsia, whatever test we are doing?
Definitely. We have biomarkers which can predict even at 31
I'm not talking
weeks.
about biomarker. I'm talking about the routine test that you do for preeclampsia. Would you like to do it right now? She's non-hypotensive right now.
Definitely will, because she had already lost one baby. I will take her at a high risk, and
Ma'am,
test
ma'am, there are cases of late onset PIH also. Late onset PIH also, ma'am.
उसका umbilical artery और uterine artery बिल्कुल कराएंगे.
Everything is normal right now. Everything is normal. The blood pressure is normal. Her parameters are normal.
Even then कराना चाहेंगे.
Even then karana chahenge. Any other comment from the panelists?
Ma'am, there is a late onset PIH also. Late onset, so it can develop later also. So she has to be monitored more carefully. She has to be counseled more carefully.
Nidhi, your question. Preeclampsia matures the fetus faster, and the worry that steroids may increase the blood pressure. She's 31 weeks. Previous abruptio is already there. Would you like to use steroids in this right now?
Definitely, ma'am. I would like to. I'm a
I will also
steroid.
use,
And
so most of us will like to give, even though she's normotensive, most of us would like to give steroids right now. Saroji, you're expert.
Steroids and aspirin should also be given, because in literature it is documented that aspirin will reduce the chances of abruptio again.
Saroji has already mentioned that she will start this thing.
Actually, I will like to like one point about Preeti, that whenever we have got this history, and it is very common thing that the patient is having PIH in first pregnancy and in second pregnancy, because the primary gravida is a risk factor and with all these cardiovascular pathology. But in these cases, actually one thing is the only monitoring. I will not go biophysical. PLGF is still a big question mark, and still we are not sure that it is really recommended for a general clinical practice. But close fetal surveillance is the thing, and the surveillance. I will say, just look, don't burden with the many drugs and many things, but surveillance, that is the thing which I will like to say.
Okay, so we definitely, all of us would like to keep this patient under surveillance, everything, but how long? How long would you admit this patient? Would you like to admit her right now? There's several questions that the pregnant women will ask.
Ma'am, we would like to admit her right now.
So,
do a maternal and fetal.
So if everything is normal, Nidhi, everything is normal. She's perfectly normal right now. 31 weeks, everything is normal. Doppler parameters, blood pressure, counts, everything is normal. Now, Savita,
yes, ma'am, I will go. Yes, I will like to go for the biomarkers because at this stage, if we will go for the biomarkers, they will give the us the prediction of next 1 week whether this patient will go into preeclampsia or not. Good. If the levels are high, the ratio of serum FM like tyrosine kinase 1 upon, divided by plasma growth factor is more than 86. The chances of developing preeclampsia are higher.
I
next
differ from that
this patient.
I know there
I differ from that because of the cost effectiveness in the low resource setting. And ma'am, the positive predictive value of biomarkers is very low.
So but for the next 1 week, the predictive value is very high. It is 77%.
So let me complete what I really want to tell. Yes, true. They are costly tests, but still they are available. They are being done. They are being provided by many labs. The point here is whether they have any, because we need to know about it. It is about preeclampsia, what is new. So recent studies which are coming up, we need to discuss about them. Though we may not practice these, but still we need to discuss about them. It is very important to know, Nidhi, I do agree, they have a very low positive predictive value, but they definitely have a very good negative predictive value.
Yes, true.
So if the negative predictive value is 98.9% for these pregnant women, then definitely there is a role. I must tell you that Dr. Revati and Dr. Prakash Mehta from Bangalore, they have done a study in 50 pregnant women where the pregnant women had gestational hypertension and one set of pregnant women had chronic hypertension. Now, they actually started detecting these PLGF ratio and split-1 ratio from 28 weeks of gestation, and they found that the delivery interval was increased and the outcome was much better using these tests. So it is very important for us to actually, I was just telling, and you can take up these studies even in the PGs because these are very, very important and relevant tests. Yes, and this was a paper that I'm talking about. This has been published in International Journal, a very much study done in India by Dr. Revati and Dr. Prakash Mehta. And we had a lot of discussion on this when we had the preeclampsia session regarding this. So Anu, can you read out this chart?
Yeah, sure.
This is very important.
If on doing biomarkers, we are taking ratio of soluble FMS like tyrosine kinase 1 and PIGF ratio. If the value is less than 3, these patients are categorized as low risk patients. They can be maybe gestation less than 34 weeks. So how to follow these patients? If the gestational age is less than 37 weeks and risk ratio is low, that is less than 33, we have to do this ratio, biochemical markers and conventional tests for fetal well-being every 2 weeks up to 35 weeks as clinically indicated. And in the cases that are having gestational more than 37 weeks, tests for fetal well-being are advised twice weekly. We have to increase the frequency of fetal monitoring. If they are stable, we can take them till 38 weeks to 39 weeks of gestation, and we can plan delivery accordingly. If these cases come in, the ratio comes between 33 to 85, it is intermediate risk ratio. For gestation is less than 34 weeks, and for ages more than 34 weeks, this ratio is 33 to 110.
So that means I want to here specify that if the values are more than 85, then these are the pregnant women whom we really need to admit. Otherwise, you can just monitor these patients on the OPD basis. So here is the relevance.
I just wanted to ask, what is the cost of this test?
The cost is, see, the labs are, Roche is also providing this. And if you, because this was taken up for this study, so it is around 2,000 something rupees. And if you just can take up for the studies, I think Roche will be very happy to provide you the discounted price for this. But definitely these are the cases, like I'll give you some more examples for this. Suppose if a patient develops a liver dysfunction, like a SGOT, SGPT is raised,
there is a pregnancy-induced thrombocytopenia, a borderline hypertension, a borderline once, maybe 130, 90, her blood pressure is. Sometimes we get confused whether this is a case of preeclampsia going into health or this is a liver disease. So these are the biomarkers where they definitely have a definite role.
Right.
It is very, very important for us to accept it. Whether it will be feasible or applicable in coming years, it is yet to be questioned. But definitely there are studies, a number of studies. Dr. Sarosh is also involved in this, and she's a leading OBGYN who has a lot of insight in preeclampsia. Now, again, coming back again to this question, I think we'll skip this. Antihypertensives, we have talked a lot about it. Now, Amrita, just you're coming tight versus non-tight control. A lot of discussion was happening. What should be the ideal blood pressure level that you're looking at? 140/90, or you want it at 135/85, or you want it a diastolic blood pressure of 80, 130/80? What is your aim of when you put these patients on antihypertensives?
See, very tight control is not desired because as per the changes in the preeclampsia, she's having generalized vasoconstriction. So too tight blood pressure control will lead to compromised placental circulation. So the goal is to maintain diastolic blood pressure up to 85 and not below 80, and systolic blood pressure up to around 130 to 150, not below that, because otherwise she will have problems with the reduced placental flow.
So Shikha, can you just tell me how you titrate antihypertensive drugs? Just quickly, last 2 slides more. Quickly tell us how you titrate. Suppose if you're putting a patient on labetalol, 100 milligram BD you have started, the blood pressure is not being controlled. Then you make it 100 TDS. Then how you titrate actually?
Usually commonly drug use is labetalol. So we started with the 100 milligrams BD and we increase the dose to 200 BD or even 400 BD, and maximum dose which we can give it up to 800 TDS also for the labetalol. But in my own practice, normally it has been said that 800 TDS, that is 2,400 grams of labetalol, can be given in a day in a divided doses. But what we do is after, if we are not able to make the control titration, which we are doing at our setup, is after 400 BD or 400 TDS, if it is not under control, we add on with the another calcium channel blocker simultaneously, that is nifedipine. And this is how we try to manipulate, and then we do it in a different timings. We settle out for these two drugs.
So very basic thing. Thank you so much. The basic thing is you start with low dose, increase to medium dose, and once the blood pressure is not being controlled, add the other antihypertensive. This is very important. And this is how you do. And nifedipine, it is always a sustained release, which is important rather than the simple form. Now, Saroji, your comments on antihypertensives, preferred one, labetalol or nifedipine?
I agree with Shikha because after reaching to 300 TDS with labetalol, I will not like to increase it more. Instead of that, I will like to add another antihypertensive like nifedipine instead of increasing its dose. That is what you're doing.
Commonest, which one you are using, nifedipine or labetalol?
Labetalol first choice, definitely first choice. But secondly, if I have to add, then nifedipine. And of course, not at all sublingual, that we all know that. And even nifedipine, not the long-acting ones, because many times we have to monitor these cases, so not the long-acting one. OD wala nahi.
You are not using hydralazine.
Hydralazine for parenteral use, again, first choice.
Actually,
we are using this labetalol. मैडम यूज कर रहे हैं हाइड्रोलाजीन सिर्फ उन केसेस में जिसमें कि वो एस्मेटिक है या सीवियर एनीमिया रहा, पल्मोनरी एडीमा है।
पर पता है गवर्नमेंट सप्लाई में हाइड्रोलाजीन आ गई है, तो सब CHCs तक में अवेलेबल है।
जी
तो इसके यूज को बताना चाहिए CHC वगैरह में, जिससे वो यूज कर सके।
मैडम जो CHC वालों की वो लेते हैं, ट्रेनिंग लेते हैं, उनको दोनों सिखाते हैं।
मैडम प्रीति, आप बताइए।
जब हम लोग रियो में गए थे मैम, उनकी फर्स्ट ड्रग ऑफ चॉइस हाइड्रोलाजीन।
हाँ, वही तो
फर्स्ट ड्रग ऑफ चॉइस
यही।
लास्ट कमेंट प्लीज, म्यूट एवरीवन। लास्ट Please mute everyone.
मीटिंग चल रही है मेरी।
Mute कर दीजिए please. Rihanna, last question to you. When can she plan her next pregnancy? Now she has delivered. She had normal pregnancy, normal vaginal delivery. Everything was normal. She was delivered at 37, 38 weeks. Now she wants to plan her next pregnancy. What preconception counseling can be offered? Rihanna.
Yes, like before planning her next pregnancy, she should be like investigated for the secondary hypertension, like what was the causes of hypertension in this patient. Was there any component of Aplar syndrome? She should be investigated for that. If there is any renal medical disease was there, renovascular hypertension was there. Is there any component of hypothyroidism was there? Anemia should be investigated, and like metabolic syndrome, her lipid profile should be done, and she should be investigated for PCOS, insulin resistance, and GDM. If she is likely to develop diabetes mellitus, or she is having diabetes, all these things should be first investigated, and if they are like controlled, controlled, then she should plan her next pregnancy.
Thank you so much. तो रिहाना, बच्चे को नहीं आगे मॉनिटर करना है, सिर्फ माँ को करना है.
नहीं, definitely baby perinatal monitoring baby also needs, because it has been seen कि these babies, they are likely to develop hypertension in childhood. Yes. They are more likely to develop these diabetes, hypertension. They are more likely to have.
Like GDM, preeclampsia is again a risk for LCD to both the generations, even mother and also the baby. So final comment, Saroji will close this panel now.
नहीं प्रीति जी, बस एक बात ये कि उसको इतनी अच्छी काउंसलिंग देनी है कि अगली बार वो 31 वीक्स पे ना आए, अगली बार वो जल्दी आए, जिससे कि उसका हम लोग प्रिवेंशन के लिए एस्पिरिन वगैरह दे पाएंगे. करना है.
So final comment, Saroji, you are expert. You give your final comments and then.
फाइनल कमेंट्स तो आपने बहुत अच्छे से, बहुत बढ़िया से सब कराया, और प्रिवेंशन और प्रिडिक्शन वाली बातें भी बहुत अच्छे से मैनेज हो गई. और बस वो कुछ चीजें जो हम लोगों को सच में अपनी ओपीडी में स्टार्ट करनी है, वो मीन आर्टिरियल प्रेशर जो अभी भी हम लोग नहीं कर पा रहे हैं, वो कराना है. और जो हमारे पेरिफेरी पे लोग बैठे हैं, उन सबको एंटी हाइपरटेंसिव, स्पेशली मैक्सेल्फ और लेबेटालॉल आईवी कैसे लगाना है, वो हम और अच्छे से.
सरोजी, अभी हम अहमदाबाद गए थे डॉक्टर अल्पेश सर की कॉन्फ्रेंस में, तो उसमें वो एक्लेम्सिया का हम लोग को स्टेशन दिया गया था करने के लिए. तो हमने वो क्विज से शुरू किया था. आप बिलीव नहीं करेंगी, काफी डॉक्टर्स को मैक्सेल्फ रिजीम नहीं पता थी, क्योंकि वो हमने इतना कंफ्यूज कर दिया था कि इंट्रामस्कुलर 4 ग्राम लगना है कि 5 ग्राम लगना है, तो उतना भी नहीं मालूम था. तो वो चीजें इवन डॉक्टर्स में भी हैं कि वी हैव टू रियली लुक इनटू इट अगेन एंड अगेन. अपने हेल्थ केयर वर्कर्स को बताना है. मैक्सेल्फ रिजीम जो हम लोग प्रिचार्ड रिजीम डे इन एंड डे आउट बताते हैं, उसमें भी कंफ्यूजन था कि उनको लोडिंग डोज
सबको सेम बतानी है. ये बहुत सबको एक ही चीज आए, जिससे कि कंफ्यूज ना हो कि इंट्रामस्कुलर के इंट्रावेनस, सबको एक ही चीज बतानी है, वो बहुत जरूरी है.
जी. थैंक यू सो मच. थैंक यू सो मच.
मैं ना ये सब चीजें हम लोगों के जो पैरामेडिकल स्टाफ है उसको भी सिखाई गई.
इम्तिहान में वाइवा में नहीं बता पाते, और तो क्या कहो.
मान्यता बहुत अच्छा प्रोग्राम है मैम. इसको प्रीति मैम आप इसको और बढ़वाइए आगे.
हाँ,
उससे हमारा जो स्टाफ है वो भी एक्सपर्ट हो गया कि कितना ग्राम कितने.
थैंक यू अनु, थैंक यू
प्रीति मैम.
और प्रीति जी और साधना जी, आप लोग प्राइवेट सेक्टर में बहुत अच्छे से बढ़वाइए से, मान्यता से भी और सब तरह से भी. और पब्लिक सेक्टर में जैसे ईमॉक वाली ट्रेनिंग्स हो रही है, आरआरटीसी हो रही है, तो ये लोग पीएचसी और सीएचसी वाले डॉक्टर्स की बहुत सारी करा रहे हैं ट्रेनिंग. और हाथ पकड़ के अमृता भी.
ड्रास्टिक इम्प्रूवमेंट है मैम, ड्रास्टिक इम्प्रूवमेंट है.
जी, प्रॉब्लम क्या हो रही है? फंडिंग नहीं है एक्चुअली प्राइवेट सेक्टर
नहीं. एक्लेम्सिया की किट नहीं, इन्होंने क्या किया है, एक्लेम्सिया की किट उनके बिल्कुल अलग से दे दी है. एक अपनी कोऑर्डिनेटर वहां लगा दी है हर पीएचसी सीएचसी पे, डिस्ट्रिक्ट हॉस्पिटल, मतलब बहुत सारी चीजें करी है.
नहीं है, वो नर्स मेंटर है जो रखी गई है.
गवर्नमेंट सेक्टर में तो मैम हो जाता है, लेकिन प्राइवेट के लिए फंडिंग नहीं मिलती है, फंडिंग नहीं कोई देता है. इट इज वेरी डिफिकल्ट.
मरीज लाता है ना, मैक्सेप तो मरीज लाता है, उसमें फंडिंग कहाँ करते हैं?
नहीं, ट्रेनिंग जो आप बात कर रही
सबको हम जा रहे हैं.
नहीं मैम, रुकिए, अभी रुकिए.
सरोजी, हम सोचते हैं कि कुछ हम लोगों को. हाँ, यस मैडम.
सुबह से हम नारची में एग्जाम ले रहे थे और वहां से 5:30 बजे आए और यहाँ 5:30 बजे बैठ गए साधना को सुनने। और आजकल तो साधना को सुनना जरूरी है भैया, प्रेसिडेंट है ना भैया आगे की।
मंजू जी हाथ जोड़ के धन्यवाद, आपने हम लोगों को ज्वाइन किया और हम लोगों का हौसला अफजाई की। दोनों मंजू जी को।
सरोज हम तो ट्रेसपासर हैं क्योंकि फैकल्टी नहीं थे फिर भी घुस गए।
नहीं तो आप तो फैकल्टी हमेशा हो ना यूपीसीओजी की, और आप सुरक्षित मातृत्व हमेशा एवर।
मैं तो हर जगह की फैकल्टी हूँ यार, मुझे
मैडम बस उषा जी को अभी जस्ट छोड़ना पड़ा, अभी उनका फोन आ गया था, बोली कि बहुत एसेंशियल कुछ काम हो रहा है। मैंने कहा कोई नहीं, सब लोग संभाल।
अरे उनको तो माफी है सब।
मीनल चलो वोट ऑफ थैंक्स एक्सटेंड करो।
मीनल चलो
बस हो गया।
चाह रही थी
बहुत सारा हाथ जोड़ के सबको
बस छुट्टी करो। आप कुछ मत पूछो, वोट ऑफ थैंक्स दो, फोन करना। अब तुम हमारा गला बहुत बैठा हुआ है।
तो हम नहीं ज्वाइन करते कोई हाल नहीं, नहीं हटाओ उसको तो कभी भी।
मैम जो स्क्रीनिंग की बात करी है हम लोगों ने सारी, प्लेटलेट इंडिसेस का बहुत इंपॉर्टेंट रोल देखा गया है फर्स्ट ट्राइमेस्टर में। प्लेटलेट टू लिम्फोसाइट रेशियो और थ्रोम्बोसाइटोपिनिया और इंक्रीज प्लेटलेट वॉल्यूम, इस पर हम अपने डिपार्टमेंट में एक थीसिस भी कंडक्ट करा रहे हैं। और इसको हम सिवियरिटी से लिंक करा रहे हैं, देख रहे हैं कि प्रेडिक्शन में कितना एसेंशियल है ये। और अगर ये मार्कर आ जाता है तो ये बहुत ही इकोनॉमिक रहेगा सिवियरिटी प्रेडिक्ट कराने के लिए। तो ये छोटा सा बात शेयर करना चाहती थी।
और मीनल नेक्स्ट वाली थीसिस में ये वाला टॉपिक दे देना, एसएफएलटी और पीजीएलएफ वाला।
हाँ मैम वो बहुत महंगा है,
प्लेसेंटल ग्रोथ फैक्टर का चंद्रा जी ने एक थीसिस कराई थी बहुत साल पहले, बहुत ही साल पहले।
एक्चुअली बायोफिजिकल
चैनल ब्लॉकर का सब बहुत सारी कराई है।
थैंक्स बोलो।
बोलो।
चलो बहुत बहुत धन्यवाद प्रीति जी, आपने बहुत अच्छी जॉब किया।
Thank you so much everyone for your valuable time, for your precious share of knowledge. I thank the audience for their active and successful participation. This academic event is a real success. Thanks to the MQR people for an efficient coordination and organization. Thank you everyone. Have a pleasant evening. Stay safe. Bye bye.
साधना को ब्लेसिंग्स, विजयी भाव।
Thank you. बिल्कुल बिल्कुल।
थैंक यू सर, थैंक यू मंजू मैम, थैंक यू।
साधना बहुत बड़ी पार्टी देनी पड़ेगी।
कोविड में वर्चुअल पार्टी हो जाएगी।
पंडित लोग
खाने नहीं लेंगे, लखनऊ आके देना।
नहीं, पंडित लोग तो खाने में इंटरेस्टेड रहते हैं खाली। और गोरखपुर तो हम जाने वाले नहीं खाने।
अब वही आके
लखनऊ आके देना, हम लोग भी वहीं आ जाएंगे।
हाँ लखनऊ सेंट्रल प्लेस है वो। और कोरोना भगा के आना।
हाँ वो शुद्ध लोगों को बुलाइए, देखिए कोविड कभी जाएगा, ये जान लीजिए।
चलो प्रीति, ऑल द बेस्ट, हमारा कोविड ना आए। बाय बाय सबको, बाय और थैंक यू।
मंजू जी चंद्रावती मैडम को कहिएगा हम लोगों ने मिस किया, वो उनका फोन तो आ गया था।
वही तो मैंने तुरंत फोन किया, पता लगा ओटी में है।
जी मैम जी।
हाँ चलो ठीक है।
थैंक यू एवरीवन, थैंक यू।
समझ लो हम लोग रिप्रेजेंट कर रहे हैं उनको।
जी मैम जी मैम।
गीता
तभी तो कह रही थी जो सीख लेना वो हमको बता देना। तुमने कहा प्रीति बता देगी।
ठीक है, ओके मैम,
थैंक यू। दे देना। बाय बाय।